formal conference, convention. Yesterday we had a training program for the student and junior doctors. Today we are having the main conference. And I request just one announcement. We'll have a tea will be available, tea and snacks will be available between 10 and 11. But before that, going to the tea, I would suggest to have the food coupon, lunch coupon. Sometimes they may ask the lunch coupon just to show that. So that, and the lunch will be from in the main hall, just in front of the college. I request our scientific committee convener, Dr. S. Vasudevan, to do the formal welcome.
Good morning. It's a great honor to be the convener of this scientific committee of Platinum Jubilee Medical Convention. I have Panikar sir has already welcomed everyone. So my job is to highlight certain things. One, we have a very long day of academic programs today. So we need to be very prudent in time management. Our team will tell us what are the ground rules today. Second thing is, we have this same thing going in FB Live as well as in YouTube. So the link has been shared to everybody. Please share it with your friends so that more people can watch our faculty. Thank you. Over to the announcing team. We will have our Vice Chancellor to formally open this session, which has been named appropriately as the KUHS session. Over to you, sir.
A very good morning to you all. Professor Robert Gallo, Professor Andres Wine, Ms. Nora, former Vice Chancellor Dr. M.K.C. Nair, Gagandeep Kang, eminent faculty members, and my dear students. Kerala University of Health Sciences is extremely happy and proud to organize this session on virology along with Trivandrum Medical College Alumni Association. Till recently, all of us thought we have won the war against infectious diseases, against viruses, against bacteria, and suddenly COVID jolted us, shattered us, and now we suddenly realize viruses are here. And they have been here millions and millions of years ago, even before the human being existed. And they are in number, millions and millions in time of the number of human beings. In fact, they are our seniors, and they have the capacity to destroy the human race. We had battle with viruses, and very often we lost many people, but we have won. But now we realize we should have an organized defense against these viral infections. And that's one of the defenses is the global virus network, and which was launched by Professor Robert Gallo and others. And this meeting again is a defense against viral infections. The One Health concept launched by WHO is again another defense against the viral attacks. We have to survive, and we will survive. And this survival can be done through sharing knowledge, creating knowledge, and that's why we are here. And That is the business of any university, and Kerala University of Health Sciences is doing exactly that. Now I come to the formal welcome. Professor Robert Gallo, the man who chased the AIDS virus and who narrowly missed the Nobel Prize from Institute of Human Virology, Baltimore. Unfortunately, he could not come personally because of technical reasons, but he will be talking to us from Baltimore online. And in addition to that, today evening, we are releasing a book written by him, Chasing the Virus, which is translated in Malayalam by one of the most eminent translators of Kerala, Sri Kunjakrishnan. Today evening, we will be releasing that legendary work. Now, we have the other speaker, a living legend on virology, clinical virology, Professor Anders Wein. And he has come from Karolinska Institute, Sweden. And Karolinska Institute, we all know, the institute which decides who will get Nobel Prize this year. And he has come from that great institute. Welcome, sir. Thank you to. He is coming to India for the first time, and he has come straight to Trivandrum Medical College. Along with him, in fact, Robert Gallo has sent the coordinator of the global network against global virus network, and Nora, she has come from Baltimore. Welcome, Nora, and she will be coordinating all these programs. And now, India's defense against COVID, Gagandeep Kang is here. She has come from CMC Vellore. Welcome, madam, to this meeting. And this session will be chaired by the eminent virologist, eminent Sri Kumar, Dr. Sri Kumar. Sri Kumar is the director of Institute of Advanced Virology, and Institute of Advanced Virology is Kerala's defense against the viral infections. Welcome, Sri Kumar. And Professor Indu, faculty of Kerala University of Health Sciences, and currently the Professor of Community Medicine. She is co-chairing. Welcome, Dr. Indu. And I welcome all other faculty members, and now the session is open to you. Dr. Sri Kumar and Dr. Indu, please take chair and we will start the program. First, we will have the online talk by Robert Gallo.
Good morning and welcome to a very interesting session on virology. And thanks to the COVID pandemic, this virology has become all the more important in our life. Even though we have been facing these pandemics many times, maybe H1N1 influenza, chikungunya, Zika, and all other kinds of pandemic for the last, maybe we can call this century a century of pandemics. Maybe there are multiple reasons for increase in the number of pandemics now, but COVID has changed all our perspectives on this pathogen. And we had to unitedly fight this organism, or you can say this entity. And now this session is going to be one of the important sessions in the whole program. So I have Professor Indu PS as my co-chair. She is the professor of preventive medicine in Government Medical College, Paripalli. I thank the organizers for this opportunity, and I consider this as a privilege to be here to talk to you and introduce eminent speakers in the field of virology. So we have 3 speakers for the session today. Professor Gallo, Robert Gallo, all of you know him. He has been introduced sufficiently. And we have Professor Anders Wein. He will be talking on monkeypox and future challenges. And we have Professor Gagandeep Kang. We all know her, her eminent stand on the COVID management and how she has made a very beautiful institution or brought the Translational Health Science Center into the forefront of virology in the wake of COVID pandemic. So we will listen to all these speakers, and I will not take too much of your time. Let me start introducing Robert Gallo. All of us know about him, and he is a co-discoverer of the HIV-1. And interestingly, his first discovery was on the human T lymphotropic virus, where there was actually a person from Kerala who was as the first author of the science paper that was published. Dr. Sharangadharan was one of the first authors in that paper. So we should be happy that we had a long-standing association with him. And interestingly, he also contributed in multiple domains of the HIV disease per se, like identifying the chemokines, identifying the T cell growth factor, that is the interleukin-2 that we call now. So his laboratory in the NIH, the Cancer Institute laboratory, has played a multiple role in the field of this disease. And he worked for 30 years in NIH, and now he is extremely active. He has started the Institute of Human Virology in Baltimore. I was fortunate to be in Baltimore in Johns Hopkins for around 9 months as a part of my Fulbright fellowship. But unfortunately, I didn't find time to visit this institute, but I was passing in front of the institute many times. And every time I used to think I should visit the place, but I could not get time to visit the place. But it's a very beautiful city, the Baltimore, and I had a very, very interesting time there, and she will vouch for it. And I could not visit the place, but so it is. I understand that it's an excellent institute that is coming up in multiple domains of disease management, viral disease management. And he was elected as the member of the National Academy of US Sciences, and also he received the Lasker Award, which we call as the predecessor for the Nobel Prize, 2 times Lasker Award. Maybe because of some unfortunate decisions, he lost the Nobel Prize, but he is extremely active. And the global virus network that he has managed to conceive and trying to organize it in a much better way, or trying to coordinate all the virology activities, is one of the major activity that will take shape in the future. So I welcome Professor Gallo for this meeting, and let us start with the session. Maybe the other 2 speakers, I'll give the, okay, yeah, Dr. Indu wants to speak later, so we'll start the session. Thank you for this.
Greetings, to my friends and colleagues in Kerala and anywhere else this might be being observed. I first want to say I'm very sorry and apologize to you for not being there. I had promised my friend Professor Pillai I would come to Kerala. I've been there twice before. I've always had a good experience, wanted to come, but I have conflicts at the institute where I am director, the Institute of Human Virology in Baltimore at the University of Maryland. I am Robert Gallo, and I am also the co-founder of the Global Virus Network. I also have another conflict for being with you that would have prevented me from going. I just recently had a severe case of COVID where I had to go to the hospital. So under any circumstances, I would not have been able to have made this trip. However, I am very happy to say you have an outstanding virologist with you who is more than replacing me. He might have come anyway. He is Professor Anders Valny, professor in virology at the Karolinska Institute in Stockholm. In my mind, Professor Valny is one of the most scholarly virologists in the world. He has a wealth of information. I hope you will take advantage of it. I'd like to start more formally by saying a few words about the Global Virus Network, which Professor Valny is also deeply involved in playing a role internationally. Our idea was to create a network of the best virology people we could to cover every kind of virus and have expertise in it in order to be able to advise public health officials throughout the world and to be connected in case there are pandemics, as we are facing two right now. HIV still persists, and the COVID SARS coronavirus 2 pandemic that we all talk about every day. So in a pandemic, we have to be connected. We have to be collaborative because it involves everyone. And if it's left to simmer, to develop in a certain area of the world while the rest of the world is okay, the danger of it coming back for all, if we think even selfishly, it's in our interest to be cooperative. The Global Virus Network has no political or type of political system requirement. So consequently, we have nations from all over, including Russia, including China, including, of course, the United States, and much of the rest of the world. There are now 70 centers. I think we're in about 40 different countries and growing. When a center is not fully developed, they're often called an affiliate with the goal that they soon become a center with proper collaboration with some of the other Global Virus Network or GVN centers already in operation. I said that our goal was connecting virologists, the best ones we can, in order to respond and to advise public health officials, but it's also for training virologists. Think about it that there's always a shortage of virologists, expert virologists. Think about this, how do people go into virology? It's always been by chance, just by you happen to hear a lecture, you decide to go in virology. We think that should no longer be the case. And there should be adequate virologists trained in every place possible so that we can have the proper dialogue, the proper potential collaborations, and the proper response to new and puzzling virus phenomena causing serious disease. So that is where the GVN is today. It's growing. It's become much larger and much more active in the last, let's say, 2 years. Our president is Christian Brichot, former president of the Pasteur Institute. And the goals of the GVN right now, or let me put it differently, not the goals, is to work by task forces, the pathways. We're involved in task forces. That is, we gather together experts in a given area and have regular meetings. Of course, we have this on COVID, but there's a Zika, there's HTLV1, the human T-cell leukemia virus, #1, a retrovirus causing adult T-cell leukemia and a serious paralytic neurological disease, as well as autoimmune disease. There's a task force on that because it's not understood well enough. There's a task force that relates to HIV. There's a task force that relates to new emerging pathogens. So there are many of these task forces developed as we need. We also are unique in being able to have an outreach to industry, which is difficult for government-sponsored things, difficult for WHO, for example. We need to be interactive with WHO. We need to be involved with WHO, but we are different. The GVN is much more straightaway science. The WHO relates to all nations, necessary, important, public health, but is not close to everyday science. That's maybe the singular most important difference. And the fact that we don't, receive, we're not against receiving government funding, but so far that's not been the case. We rely on funding from a variety of sources, philanthropy, industry, etc., things like that. So there's an important role of the Global Virus Network, and there's a great need for a center in India that's very strong. And in this regard, Kerala has emerged. Through the great help of our friend, Professor Muni Pillai, a center is established in Kerala, where we know there's a lot of interest in medicine and medical science. One has to only visit there briefly to see how many medical clinics there are in a short distance. We believe Kerala has a chance to really be a leader, not just in India, but maybe in Asia, maybe someday a regional center for a good part of Asia. Also, its importance is highlighted by another problem that India, and especially southern India, face problems there with epidemics, diseases that are caused by pathogens, mainly viruses, that occur regularly. They're not causing a pandemic because most of these things are insect-borne, and as such, they tend to be regional where certain insects are found. But I don't have to remind you of your problems with chikungunya, Zika, dengue, and for the world, we still have HIV floating around, and now COVID as well. COVID is a true pandemic. True pandemics are something new, something unexpected, something that affects the world. When a pandemic first appears, you should think of change. Something changed to allow this to happen. Well, sometimes you can't find the change because it's in the virus. Think of polio when there was a mutation from an enterovirus, a gastrointestinal virus, that was not causing so much serious disease, thought to be in the type of virus thought to be a Coxsackie, but it became, a variant became neurotropic and was able to cause polio. But most of them are changes in some societal way. I don't want to go through the history of this. I've talked before in Kerala and went through it in some detail. But if you stop and think of the ancient periods, the time of the Roman Empire, another big event, the time of establishing contacts with the New World from Europe to the Americas, epidemics. When you think of HIV, think of changes that allowed it to spread after World War II, travel, sexual promiscuity, blood for medical purposes. These things fanned the flames and made it a pandemic. We don't know what change occurred to allow SARS coronavirus 2 to become the pandemic of COVID. Change still must have been there. Was it in the markets? New sources of animal food? We don't know that yet. Or was it just a certain mutation in the spike sequence of the virus that allowed this to emerge in such a terrible way? Another generalization I'd like to make about pandemics is that we tend, well, not tend, we always forget. I've heard many commentators say we will never forget the COVID pandemic. Well, that may be true because it goes on and on. So that we're here year after year, but with other pandemics, we always forget. After a generation or a generation and a half, say 25 to 30 years, if you look at the history of the pandemics of the last century, they've been due to viruses, they've been all due to RNA viruses, and we forget all the time. We even forget about HIV, even though it continues to infect about 38 million people in the world, a particular problem, as you all know, in Africa. Sometimes pandemics will have positive spin-offs. In other words, maybe a silver lining on a black cloud. We can say that the HIV pandemic brought us closer together between North and South. For example, the United States helping to Africa became very significant for the first time in public health, in a way far larger than it had been in the past. It also brought about a greater appreciation and understanding of differences in sexuality. So and it also, certainly in the United States, brought us had to look in the mirror and see that our public health system needed to return to better days, and we needed to be more involved, and to hopefully, and we think GVN will contribute to this, hopefully never forget. And a continued GVN presence will help us never forget. I don't want to go into more detail because this requires slides, it requires an hour's lecture. And I think that this outline is as much as I really want to do. But I want to end with something important. I want to express my personal thanks and appreciation to Professor Pillai for his friendship, for his connections to Kerala, and for the translation of my book, Virus Hunting, hopefully for people there to become familiar with. it was written more than 3 decades ago, the period of 1988 and 1989. However, there's nothing in there that I would really take out. It's still applicable today, though of course it doesn't have COVID, it doesn't have some of the epidemics in any significant detail that you face. It has a lot of HIV, it has a lot about retroviruses, and I hope you'll get a chance to look at it, and if you do, I hope you'll think it's worthwhile. I wish you success with conference, and mostly I wish great success for the new Kerala Center in Virology of the Global Virus Network. Thank you.
That was Professor Robert Gallo. Dr. Nora Rebecca, please accept our appreciation and gratitude and communicate that to Professor Gallo. We'll take up questions at the end after the 3 presentations are over. Now we move on to the next speaker, Professor Anders Vaughan. He was former chair of Division of Clinical Microbiology and Virology at the Karolinska Institute. He was well introduced by Dr. Mohan R., Vice Chancellor. He was also the Chief Physician at the Clinical Virology Diagnostic Laboratory at the Karolinska. He serves as the Director for the Karolinska Center of Excellence at the Global Viral Network and is a co-chair of GVN's Task Force on Lone COVID-19. He is a member of the GVN Board of Directors and the GVN Executive Committee. He was on the President's Advisory Board for the Irish National Virus Reference Lab at the University College Dublin from 2010 to 2021. For a long time, that's from 1972 to 86, Vaughan's research focused on neuropathogenesis of herpes simplex virus infections. Thereafter, he switched to mainly work on human retroviruses, in particular HIV. In tune with the current monkeypox outbreak, we also had 4 cases of monkeypox from Kerala and around 10 from all over the country. Let's now listen to Professor Anders on the status of monkeypox and the future challenges. Professor Anders.
Well, thank you very much. And first of all, thank you. I'm very honored to be invited here to Kerala and to this conference. I'm also, as you may have heard, this is my first visit to India. Today I will talk about monkeypox. I've not been working on pox viruses, and very few have for the last 4 decades since we eradicated smallpox. But it's a very, very interesting virus. And how do I change slides? Is there? Here? Lovely. So monkeypox is a pox virus, and it's, you see here to the left, that it's an orthopox virus, and among orthopox viruses is the variola virus, which is the virus that causes smallpox. It's vaccinia virus, which is a cowpox virus, and which the virus we use to produce vaccine against smallpox, but also against monkeypox. Oh. Jesus. Okay. Got stuck. Okay. So here's a cartoon of a monkeypox virus. These are large, linear double-stranded DNA with quite a large genome, almost 200 kilobases, and it has 190 overlapping open reading frames. And this is a electron micrograph of pox viruses. So monkeypox virus was first identified in 1958 in cynomolgus monkeys in Denmark. But then we didn't know of any human cases until 1970, when a child in the Democratic Republic of Congo was identified. Now we know that there are two distinct clades of the monkeypox virus. One is from the Congo Basin of Central Africa, and then the West African clade. And these have always been zoonotic infections, and the reservoirs has been mainly rodents, as you can see here in the slide, but also infection of monkeys and non-human primates. And of course, other species can be infected. For instance, prairie dogs that were infected by imported rodents from Ghana in the US of 2003, and there were like 60 people infected from the prairie dogs. So, as I just said, it's endemic in Central and West Africa. And now, with the new pandemic that started this year, really in May this year, the virus will be renamed. So it has not been so far. But obviously, monkeypox is not a very good name. And so what the new name is, we will not know. And as I said, there are two distinct clades, the Central African clade and the West African clade. Also, these clades will be renamed. And the Central African clade will be called now clade 1, and the West African clade will be named clade 2. And the West African clade, or clade 2, now has two subclades. One is the original clade found in Western Africa, and then another subclade, which is a strain circulating now in non-African countries. And this is a WHO slide just showing where you find now cases of monkeypox outside of Africa and also in Africa, of course, as you can see. And this clade are a few weeks old. Now we think there are about 35,000 cases, or more than 35,000 cases in the world. But you can see the most cases now are in the Americas and in Europe. And the transmission has been by handling animals, for instance, bites or close contact with the animals, and also in abattoirs dealing with animals. The human-to-human infection has not been considered very efficient, and that's why there hasn't really been any pandemic or big outbreaks of human-to-human infections, except now. And now it's believed to be close contact, sexual intercourse. And outside Africa, in this year, close to 100%. In the US, for instance, 98% in one big study are men who have sex with men that are gay or bisexual. So here's a slide just showing the transmission route. You can see that there's no pointer, is there? Oh, yeah. So bites, and then hunting, cooking, and so forth. Blood fluids is the animal route. And then you have the human to human, and I just described this. And now, with this new pandemic, you can see that sexual encounter is by far the largest transmission route of monkeypox. This year, on July 23rd, the Director General of the WHO declared monkeypox a public health emergency of international concern. And as I said, as from the WHO figures, is that more than a week ago, there were more than 35,000 cases in 92 countries, but only 12 deaths reported then. So when you look at the fatality, case fatality rate, you can see that clade 1, formerly called the Central African clade, the fatality rate has been around 10%, whereas the clade 2, and now clade 2A, found in Western Africa, the fertility rate has been around 1% or even less than 1%. Now with the clade 2B, the good news is that we only have reported 12 deaths in more than 35,000 cases, which would give a case fertility rate of 0.03%. Now for the clinic, there has been increased risk for young children and for immunocompromised persons, including those living with HIV. We don't have any good figures yet on how treatment, antiviral treatment, and if they're contained, if the virus infection is contained in the HIV-infected individuals, how that affects their infection with monkeypox. But most probably, my belief is that there would be no more risk than other persons. Now, what describes monkeypox, it's a pox virus disease. So you get these lesions in the skin. And here you can see it starts with just a rash, and then you get macules, and then papules, and then vesicles. And the vesicles turns into pustules, and then you get the crust and then scars. Now, if you take chickenpox, which is caused by a totally different type of virus, which is the varicella zoster virus, which is a herpes virus, these different stages appear at the same time. So if you look at the patient, you will see macules, papules, vesicles, and pustules next to one another, and even a crust. And which was the way you actually could distinguish chickenpox from smallpox. Another difference between smallpox and chickenpox was that the chickenpox lesions were on the body, centrally on the body, and whereas smallpox were more on the extremities and the head. Now that was not always so easy to distinguish. I can tell you, in the last smallpox epidemic we had in Stockholm, and this was in, if I remember correctly, in 1969, the professor of infectious diseases demonstrated a typical case of chickenpox to the medical students, and it turned out to be the first case of the smallpox in that epidemic. So here are this slide, it's in the wrong place, but never mind. So here you see the epidemiological curve of the outbreak now, the pandemic that started early May. And you can see that the red is the European region cases, and the blue is in the Americas, mostly in the US and Canada. So early symptoms are fever, lethargy, myalgia, headache, generalized rash, and then lymphadenopathy and development of lesions. And as I told you, 98% or more are through homosexual close contacts. And you can see now that in the distributions of the lesions. So you now have anorectal lesions, and then anorectal pain, proctitis, tenesmus or diarrhea. You have also pharyngitis, odonophagia, epiglottitis, not so common, but still there are a few cases reported. Oral or tonsillar lesions, and also a few cases of conjunctival mucosa. And just to show you here that these lesions, which are, as you can see, here perianally, and they can be also in the rectum or in the inside. Of inside anus lesions, which are very, very painful. And unfortunately, there can be only quite a few patients only have one single or maybe 2 or 3 lesions, which can then be misinterpreted as, for instance, syphilis, and that has happened a lot. I think I'll skip this slide because I can see now it's too busy. There are complications with this new clade 2B, and those are pneumonias, encephalitis, keratitis, as I just told you, and secondary bacterial infections. There is now therapy, and before this new antiviral, tecovirimat, people were using sildenafil, but it's not really used anymore, and it's kidney toxic too. So this quite good effects of tecovirimat. And as you can see, what the the European Medicines Agency, EMA, says in their website, that tecovirimat works by interfering with a protein called VP37 that is found on the surface of orthopox viruses, including smallpox, monkeypox, and cowpox. By interacting with this protein, the medicine prevents viruses from reproducing normally, slowing down the replication, the speed of infection. Now, this drug was actually developed for smallpox and for military use. Other treatments that have been used is vaccinia immunoglobulin, because there's this very, very strong cross-reactivity between the vaccinia virus immune response and the smallpox virus. Now, we have a vaccine, and so we have now also post-exposure vaccination. There are now 2 vaccines really, because after like 1980, there has not been, we eradicated smallpox from the world. But there are smallpox in freezers in the US and in Russia, we know. And we're afraid that it could be used for terrorist purposes or for biological war purposes. So particularly, as we know of, the US military has bought and stocked vaccinia virus vaccines, millions and millions of doses. But that's the vaccine we used to eradicate smallpox would never have been allowed today because quite a few people actually died from it, particularly those with atopic eczema or immunocompromised patients that were getting a generalized infection with the vaccinia virus. Now, there has been development of the vaccinia where one has made it so that it does not replicate in human cells. And the most common modified variant is what we call vaccinia modified ankara. And one vaccine against smallpox is UNIUS by Bavarian company in Denmark. And since the monkeypox outbreak, it really bloomed, and the stock exchange just hit the roof of this small company. Because this vaccine can also be used for monkeypox. And as you can see, I told you, you can use it for post-infectious, post-exposure prophylaxis up to 4 days, prevents disease altogether, and up to 2 weeks it will alleviate the infection. So why do we have a new current global outbreak, or the first outbreak? And we think we know now that there is changes to the virus. It's a new subclade. Changes in behavior, waning smallpox immunity, because it's like 50 years, or at least 40 years since people were were vaccinated against smallpox. Relaxation now after the coronavirus disease, or the COVID pandemic. Resumption of travel, amplification of transmission through sexual networks, and which we think is one of the major reasons for this outbreak. So, looking into the future, we really learn how to recognize cases. And that was important already on smallpox, like I just told you about the experience we had in Stockholm. So, and not mistake cases for other CTDs like syphilis. Testing of PCR is now still expensive, but there are developed techniques that actually can be done bedside, and which are very, very cheap. They have not been approved yet. But I know at Karolinska they are developing such techniques. We know that this virus also will infect heterosexual people by contact with homosexual people without sexual contact. And for those we know are at risk, there could be and should be pre-exposure prophylaxis, and then particularly with the vaccine and not the antiviral. They will be spread to other populations, and we have to be on our toes. And vigilance is required. So, just on time, thank you very much for listening to me. Okay. Questions?
Thank you, Professor Valle. Please. We'll have the next speaker continuing, and we'll have the discussion after the end of the sessions.
We move on to the most popular phase in Indian virology, Dr. Gagandeep Kang. She is professor in the Department of Gastrointestinal Sciences at Crescent Medical College, Vellore. She is also the ex-officio member of the working group on COVID-19 vaccines established in the strategic advisory group of experts at the WHO. She is a leading researcher with a major research focus on virus infection in children and the testing of rotaviral vaccines. Kang played a very important role in the efforts that culminated in the development of Rotavac, which is now part of our routine immunization. She was one of the 3 principal investigators in the phase 3 clinical trial of the vaccine. She also works on other enteric virus infections and the consequences when children are infected in early life. She was awarded the prestigious Infosys Prize in Life Sciences in 2016 for her contribution to understanding the natural history of rotavirus and other infectious disease. In 2019, she became the first Indian woman to be elected as Fellow of Royal Society. I think among the public also, you're very popular. When she was given an option to choose an important topic in virology for the Platinum Jubilee seminar, she chose human experimental medicine in infectious disease. Madam, please, we look forward to a futuristic and comprehensive overview of virology in India.
So good morning and thank you all for being here. When Indu asked me to choose something that would be really forward-looking, I thought about the most challenging things that we could do to really advance research and product development in India. So if we think about human experimental medicine, it has a definition. It's the use of innovative measurements, models, and designs in studying human subjects for establishing proof of mechanism and concepts of new drugs. So really, it's about using humans as guinea pigs. Now, whenever we say guinea pigs, everybody becomes a little bit nervous. And in India, we become especially nervous because, quite frankly, the idea of exploitation is one that we understand well. We have had an understanding globally of exploitation of human beings, even after Nuremberg. These are examples of studies on syphilis that were done in Guatemala and in the Tuskegee cohort that was followed up without treatment for over 40 years. Now, if the Western world can do this kind of thing to their own people, obviously in India, where we have a much more hierarchical society with much more levels of control, then thinking about experiments on humans makes us all quite nervous. But one thing we have to remember is that all of clinical research is treating people as guinea pigs. Every time we give an off-label treatment, the person who is being treated is a guinea pig. Every time we do a clinical trial, everybody who is participating in that trial is a guinea pig, effectively, right? But I think what has changed in the past few years and what makes me really hopeful about the idea of doing more human experimentation is, one, an understanding that a lot of what we learn from animals does not apply in humans. So a lot of virology, a lot of microbiology, a lot of parasitology gets studied in animal models, and then when we bring it into humans, it doesn't work, or our understanding is flawed in some way or the other. Now, I work on rotaviruses, and rotavirus is a virus that infects many species. You can have rotaviruses in horses, in dogs, you name the animal, they have their own rotavirus. And then you have human rotaviruses. So rotaviruses started to be studied in humans in the 1970s. And one of the things we really worried about with rotavirus was the fact that rotavirus is a lot like flu in that there are 2 proteins that are important for determining the immune response, or so we thought. Flu has the H protein and the N protein. Rotavirus had the G protein and the P protein, also surface proteins. So when vaccines had to be made for rotavirus, everybody focused on how many G types, how many P types can we get into the vaccine. After all, nobody uses a monovalent flu vaccine. We put in influenza A, we put in influenza B, we make sure that we have the good coverage of the H and the N types that we think are going to circulate that year. Well, we made the vaccines and we got them into people, and the drug companies came around, and one company said, my rotavirus vaccine is better because it's from a human strain, but there's only one strain in the vaccine. And the other company said, well, actually, our vaccine is better because we have many viruses in the vaccine, so all the G and P types are covered. And everybody was doing a matching of G type, P type, what is circulating in the country, which vaccine should you bring in. And lo and behold, when the vaccines came in, the monovalent vaccine worked very well. In animal studies, it had been shown that you needed to have a multivalent vaccine. Came into humans, one strain was enough. And that was really because we still don't understand a correlate of protection. But in all the subsequent studies that we have done in humans, we have seen very clearly that the immune response that protects in animals is not the immune response that protects in humans. Now, that's true not just for rotavirus, it's also true for many other viruses. And we all understand that for most things, we do animal experiments to set us up for human experimentation. When we develop any drugs, when we develop any vaccines, we take them through phase 1, phase 2, phase 3 testing. And that is looking at a lot of safety parameters and then getting to efficacy. But in all of the human studies we do, we follow ethical principles that require a study to be justified before it is done. You can't experiment on humans because you feel like it. You have to demonstrate that there is social value to the experiments that you're doing and that people will be safe. So there needs to be ethical justification, and then when you conduct the trial itself, you have to make sure that the principles of ethics, making sure that benefit exceeds the risk, that people are closely monitored, that when you come into a trial, proper informed consent has been taken, that you are doing a study that will benefit the generalizable population. All of this needs to be taken into account. So exploitation is avoided by making sure that the study is justified and conducted according to the principles of ethics. Now I'd like to come to the last 2 years and what was possible in other parts of the world and what might be possible in India. Everybody knows, in medicine at least, knows the recovery study. The recovery study, this morning's figures are that there are 48,000 participants in the clinical trial in 200 active sites. What did the UK do? They took their entire NHS and converted it into a laboratory. So every patient that came for treatment had the opportunity to participate in the clinical trial. What did this result in? An ability to harness the clinical services that we offer to actually conduct experiments, right? What did we learn from recovery? Well, recovery looked at aspirin, at azithromycin, at baricitinib, at colchicine, at convalescent plasma, dexamethasone, hydroxychloroquine, lopinavir, ritonavir, Regeneron's monoclonal antibodies, and tocilizumab. Has there ever been a clinical trial that has looked at so many different possible treatments and actually come up with answers before? Clear answers. 48,000 participants contributing to the idea that we have robust data now showing us first that dexamethasone worked, then showing us things that affect the IL-6 pathway worked, right? And then the monoclonal antibodies worked, but they worked only in people who had not been vaccinated or not exposed to infection previously. One study giving us these many answers. And the UK is a small country. Its population is less than the size of Tamil Nadu. Can you imagine if we started to do this kind of experimentation in India, the kinds of answers that we could come up with for problems that face us as well as influence global practice? Instead, we have situations where we develop products and then there are controversies about how those products are developed. We had vaccines that were evaluated in India and the vaccines came with controversies. Why? Because we don't monitor enough. Was it true that this was associated with Covaxin or not associated with Covaxin? We don't know. The company says it wasn't. The ethicists that went there say that there wasn't proper informed consent, that the conduct of the trial was inappropriate, and there isn't a final word. The product is something that is licensed, then WHO comes up and says it doesn't have good manufacturing practice, so therefore we are not accepting this product anymore. So in India, somehow, because we don't focus so much on high quality in the clinical research that we do, we wind up with products that only we use. This is true for a number of things. It's true for drugs. It's also true for many of the newer vaccines that have come into India. So since I work on vaccines, I've for a long time been focused on how we hasten vaccine research and development. Usually it takes between 10 and 15 years to make a vaccine. And for SARS-CoV-2, frankly, we got very, very lucky. Even when we started, we didn't think we would have a vaccine in a year. But ultimately, we got vaccines in 10 months. And every vaccine, every platform of vaccine that we have tried seems to have worked. But that is really not the situation for most vaccines. And there are many things that contribute to the delay. I told you that animal models don't work very well, that we don't always have a correlate of protection, how you choose which ones. If you have many vaccine candidates, how do you choose which one to take forward? One of the reasons that SARS-CoV-2 vaccines worked well was because the US threw $16 billion ultimately on the development of vaccines, right? We never have $16 billion to throw at any other vaccine targets. So we really have to choose what we are going to move forward with. So what I'd like to discuss over the next couple of minutes with you is a vaccine that was made in India and then ultimately wound up not being used by the world until it was evaluated outside. Now this is the VI tetanus toxoid conjugate vaccine, first conjugate vaccine licensed internationally. Biomed, the company, had made one vaccine, but they are a small company. They didn't go into large-scale production. This vaccine, called TIPBAR TCV, was made by Bharat Biotech. It was licensed by our regulator based on what was called phase 3 studies, but those studies were really extended immunogenicity. So you knew that the vaccine was safe, you knew that the vaccine induced an immune response, but you didn't know if the vaccine actually protected you from typhoid or not. So what did the people who wanted to use this vaccine but didn't have data on whether it was protective or not? They took it to Oxford. And in Oxford, what did they do? They made people drink typhoid bacilli, vaccinated them and made them drink typhoid bacilli and looked to see whether the vaccine was actually protecting against typhoid infection. These are called controlled human infection models or human challenge studies or human infection studies. So this Indian vaccine was evaluated in about 450 people in Oxford. It was shown to work. It protected people from typhoid. The data was submitted to the WHO, and the WHO approved this vaccine for pre-qualification. This vaccine is now in the national programs of Pakistan, Nepal, and in Zimbabwe. So 3 countries in Asia and Africa are using a vaccine that is made in India in their programs. And there have been larger scale effectiveness studies conducted in India and elsewhere that show that what was seen in the challenge study actually worked in real life also. So the question was, the challenge study used 450 people. When you have to do an efficacy trial, you have to try the vaccine in 60,000, 70,000 people. So if you can get the same answer with fewer numbers of people and a shorter time, what happens in a challenge study? You give the challenge dose to induce an infection and you can time the dose. In an efficacy trial, what do? You give the vaccine and you wait for the person to naturally develop the infection. So the numbers are big and the time is long, and therefore the studies become very, very expensive. So when I heard about this, I started thinking about, why should a typhoid vaccine trial be done in Oxford? Why not in India? The UK does not have typhoid as a public health problem. We have it. And yet we don't evaluate vaccines in our own people. We convert UK people into guinea pigs to benefit us. That seems a little bit unethical, if you ask me. So why should these studies be conducted anywhere outside industrialized countries? Do we as Indians need these studies? What's the goal of these studies? Should we be used to experiment on for a drug in the West? I think everybody would say no. But then we are quite comfortable with people in the West being experimented on for drugs that benefit us. But I think there are a lot of things we need to think about. In India, we have this guinea pig mindset. Will people volunteer? Do we have high quality clinical centers where these kinds of studies can be done? For what kinds of diseases should we be doing it for? So these were the kinds of thoughts that we went into trying to figure out, should it be done in India? And what we found was that it's being done all over Asia and Africa. In Thailand, they're doing studies on malaria. In Kenya, they've done malaria. In Uganda, they're doing schistosomiasis. Only in India, we don't seem to do these studies. And the idea is that if you have a small number of people and you follow them up really, really, really carefully, then you will get data that you won't be able to get from humans at any other time. Fixed time of infection, fixed time of investigation. And then you can do a lot more studies. You can look at genomics, you can look at microbiome, metabolome, pharmacokinetics, pharmacodynamics. All of these can be done. When we started to dive into the history of what had been done in India, we actually found that there was one person working on hepatitis E at PGI Chandigarh who had volunteered himself without his supervisor's knowledge, infected himself with HIV. This was a paper that came out in Lancet in 1993. There are, of course, with these kinds of studies, always limitations. Small number of populations means you may have issues with generalizability, you don't get long-term follow-up, etc. But I think one thing that is really important is that the infection experience of someone living in the UK and the US is not the same as the infection experience of someone living in India. So if we want an infectious disease product for ourselves, then if we want it to be suitable for us, then the fastest way is to invest in human experimental medicine in India. Obviously, there are regulatory requirements. The US FDA has an approach. The Europeans have an approach. WHO has published recommendations in 2016 for human experiments to be done for vaccine production. And in India, there was a malaria vaccine that was developed in Delhi, which has also now gone to Oxford to be evaluated in a human challenge study, because we couldn't get the methods established in India, even though in principle it was approved by ICMR. Now we have the new Drugs and Clinical Trials rules, and the draft form of the Drugs, Medical Devices and Cosmetics Act 2022 is posted on the Ministry of Health website for comments at the moment, and hopefully will become an act in the future. There are lots of lacunae in it. None of them actually address human challenge studies, and around the globe there is no direct addressing of human challenge studies. It comes generally under clinical research overall. So what is required to be done in India, that any biomedical health research has to be conducted in accordance with the National Ethical Guidelines for Biomedical and Health Research Involving Human Participants by ICMR. This again doesn't preclude the studies, but so far such studies have not really been done. We need for an ethics committee to approve the study and then for the regulator to approve this. This is an area that has been in discussion for a really long time, and there are some people that completely support the studies and some people that say, absolutely not, these studies should not be done in this country. We also, of course, have to think about monitoring, governance, anything to do with clinical research in India, we need to think about very carefully. But I will leave you with this one last slide, which is a group called One Day Sooner. It's a group that was established in response to the COVID pandemic. And essentially, it's volunteers from all walks of life who have said that if there is a human challenge study for SARS-CoV-2, we want to participate. And the idea of doing this was that that would result in vaccines being available faster. Now, there is a human challenge study for SARS-CoV-2, which has been done in the UK. In people, it has established the infectious dose in people who were not exposed previously, and there's another ongoing study in Oxford that's looking at human challenge of people who have been vaccinated before. So when we think about it, you can see here on the map, there are people from India that have volunteered also and have signed up with One Day Sooner to participate in such studies. So I think lots of potential. And I hope that in India, we will step up and, like the rest of the world, begin to do these kinds of studies, because I think they have very real potential to be able to advance the development of products that are relevant to our populations. Thank you very much.
Thank you, Professor Kang, for a very, very thought-provoking speech. And she's always known for her different thinking and radical ways she can challenge the practices that we are following in research and medicine. So we had two excellent presentations today, Professor Walian and Dr. Kang. So they can join, and we have 10 more minutes for discussion, so we can have any questions to discuss with them, we can have it. Professor Walian.
Yeah, please give a mic. So please be brief.
Certainly. Only just. Why is,
so kindly introduce yourself and
I
speak.
am Dr. Thomas Titus, cardiology professor. I want to ask you, why is the monkeypox more common in MSM than heterosexuals?
I don't think it's more cumbersome in heterosexuals than in homosexuals. The spread, it was a new clade, and I think it's because it's a new clade. For a starter, it was a subclade of the Western African clade, which is less serious than the central. The case fatality rate under 1%. So also the previous case fatality ratios were from Africa, and it could be the general health in Africa versus in Europe and in the US has lots to do with the case fertility rate right now. So the short answer is I don't know.
Thank you, Professor Anders. Dr. Anil B. Nair is Associate Professor of Psychiatry.
My question is to Professor Kang. Two questions, ma'am. Number one, is there any studies or evidence regarding the comparison between the efficacy of vaccination versus natural immunity in COVID? And number two is, a lot of governments have also initiated alternative medical practices for protection, for prevention of COVID, especially among school students. Is there any evidence base for those interventions, Ayush medications? And is there any study comparing that efficacy with vaccines? Thank you.
Both lovely questions. Thank you. So the first one on comparing responses to vaccination and infection. I think the first thing we need to remember is that most of the studies that have deeply interrogated the immune response in people who were vaccinated or infected have not come from India. So I can't speak to what the evidence is for India. We are doing some of those studies, but our cellular immunity studies aren't quite done yet, so I won't comment on that. What we do know is that in studies from the places that are closest to us, Qatar, for example, there is enough data to show that hybrid immunity, vaccination and infection combination is a little bit better than more doses of vaccine. So as somebody who's been studying viral infections for a long time, I trust my immune system and everybody's immune system to do a good job when we get infected. So having a combination of infection and vaccination seems to give you the best protection, but that's not to say that that you should not take vaccines if you have been infected. There will come a time when all of us are likely to need booster doses, and at the appropriate time, we should be thinking about taking those boosters instead of waiting for still more exposures to SARS-CoV-2. The second one about Ayush, this is always a problem in that the quality of Ayush studies, there are publications, scientific publications on Ayush trials that have been done, but those trials don't always have clearly defined outcome measures. And if you don't have a spelt out outcome at the time that you started the trial, it becomes quite subjective. So even though there are a few publications that for a few products saying that these products worked, they're really not high quality papers.
Good morning. Good morning. I am Dr. John Manika, basically ENT surgeon. Just I want to know how effective, what I understand is all the vaccines are against the alpha variety. And how much effective it is against Omicron to all the faculty. And what we are told is there is a lot of antigenicity difference between this alpha and Omicron.
So if you do antigenic mapping, antigenic cartography, basically beta and Omicron are the ones that are furthest from the ancestral strain of the virus. And therefore, with beta and with Omicron, you seem to see less protection with vaccines that are based on the ancestral strains of the virus. But that less protection relates largely to infection. Overall, it looks like protection against hospitalization, protection against death is maintained even when there is an antigenic distance of the virus. Beta, in fact, seemed to have the most severe outcomes with least protection against vaccine, and Omicron is really pretty good. Doesn't protect against infection, but pretty good protection against severe disease, hospitalizations, and deaths.
Actually, I am also a general practitioner too. I see a lot of, many patients, some of the patients have told me that immediately after taking, 1 week after taking the vaccine, they developed something similar symptoms of COVID-19. So it's because some of the viruses are not killed properly or still active in the virus.
So the vaccines that we are dealing with, all of them at the moment do not replicate. So you don't expect to have replication of the virus. What you're doing is inducing an antibody response that hopefully blocks enough of the virus getting in to cause, to be then able to replicate, cause the infection, cause severe disease, cause death. What seems to be happening with all of the newer variants is that the incubation period is coming down. And when you've got antibody-mediated immunity and you're looking at making a secondary antibody response, you actually need time to be able to mount that response if you want to prevent infection. So if you have a high level of antibodies, there is some chance of preventing infection. If the antibodies have come down and need to go up again enough to protect infection, you need for that to happen quickly, and it's not happening quickly enough. So you're not preventing infection.
Madam,
One question,
yeah.
especially to Nora. How can we carry forward this collaboration with the Global Virus Network, especially with the university, with the medical colleges, especially with our institution?
Sure. So for those that don't know, the Global Virus Network was co-founded by Dr. Robert Gallo in 2011. And he co-founded it to mitigate and prevent viral threats to mankind. And it really was an idea that came out of his experience with HIV. And he had learned from that there was a great need to have centers of excellence around the world who covered all classes of virus and were connected so that the scientists were talking to each other, and really science was put forward as a solution, and no politics and government were involved in the sense of dictating how science should be presented and move forward. So we're pleased that the Institute of Advanced Virology is an affiliate of the Global Virus Network through our great friend and colleague, Billy Hall. And so one of the things that we can do is connect again with the Global Virus Network President, Christian Berchot, who is of the Institut Pasteur. He's formerly from there. And connect on training and fellowships and on task force. Dr. Anders Volney actually heads our long COVID task force. We have started a task force on monkeypox, and we have other task forces. So we can get you involved in that way. And to join our meetings, we have meetings and conferences, and one of which was long COVID, which Anders could actually, Dr. Volney could speak a little bit more. It was a very interesting with top experts around the world speaking on long COVID. So certainly we can get you connected to our fellowship programs and other ways as well.
Madam, I want to ask you one question. What do you think would be the mortality in one day sooner
For long
project?
So if we look at human challenge studies that have been done so far, about 70,000 people have participated in human challenge studies for a range of things from malaria to viruses. Nobody has died so far.
If we take a question from Professor Sudhendra Ghosh, he was Joint Director of Medical Education.
Madam, this is being an expert in the vaccinology of our country. This question is different from the current topic because we know in our state the rabies death is going up, and people at the social media and the newsprint is finding fault with the vaccine. So how should we proceed to clear the issue? This is a big public health issue. That is why this question.
So I think everything that I do is around that. I think basically what we want is for people to trust the health system. When you say that something is good for you, it needs to be backed with evidence, and if there are questions that are raised about safety, about efficacy, we need to have solid data, and we need to be very proactive in getting it out there to say that we have data that shows that this works in this way or this is safe. No, what you're thinking of is clinical trials that have had severe morbidity. Not in not in any infectious disease challenge studies. I am aware of 6 serious AEFIs that have occurred in the 70,000 participants. None of them have resulted in mortality or in any long-term consequences.
Thank you, Dr. Kang. We are coming to the end. Just one quick comment on what are your views on the 4th dose? Some of the countries are going in for COVID vaccine, and then many companies are coming up with vaccines with the mutant variants, neo vaccines. And what do you think will be the future of COVID pandemic? That's a question common to both Professor Anders and Dr. Kang.
So in WHO's latest recommendation on 4th doses are being recommended with a minimum 4-month gap for healthcare workers, for people who have comorbidities. So only the highest priority populations to receive a 4th dose, with the caveat that countries can decide for themselves whether they want to use the 4th dose or not. Many countries have different infection histories. In India, we know that 90% of the population has been exposed to the virus now. So we do have a lot of hybrid immunity in India. So right now, from the Indian government, there is no recommendation for a 4th dose. WHO's newest guideline does say that in this very restricted population, you can consider a 4th dose based on your local epidemiology. The second question about bivalent vaccines or new vaccines based on, right now it's incremental protection if you have a bivalent vaccine. I know that Pfizer and Moderna are putting a lot of data out there saying, you know, our vaccines are going to really protect you against these newest variants. But when you actually look at the data, it's not that much more protection. And given that this is likely to be the 4th dose in most people, and we know 4th dose effect wanes very quickly, I'm quite skeptical about the bivalent vaccines. But what I am interested in, I think companies should work on it, because you need to get your methods to be able to make a new vaccine quickly if it's required. So if a new variant comes that's very distant, that we really need protection for, we should be able to make vaccines quickly. The question I have then is, do we need bivalent, or should we have a switch to the new variant vaccine? So right now, instead of Wuhan plus Omicron, how would we do with an Omicron-only vaccine? And that data we don't have at the moment. And
Future of the pandemic, sir. That's the last statement.
Yeah. Well, about the vaccines, in Sweden, people of my age, more than 60, I think now 55, have been offered, and most of them have been given 4 doses. And everybody above 60 now are recommended to get a 5th dose in September. I don't think that, you know that Britain has now approved the Omicron vaccine. and it's up for FDA to approve it within shortly. EMA require phase 3 trials, as far as I understand, and so will take a few months before EMA, the European Medicines Agency, will approve it. And I think that in Sweden it will be available only after the new year. So, and then again, how effective are the new vaccines? Well, it remains to be seen.
Thank you very much, Professor Anders, Dr. Gagandeep Kang, Dr. Noora, and my co-chair, Dr. Srikumar. We place on record our gratitude and congratulations to Professor John Panikkar, Dr. Mohan Kundumal, the Vice Chancellor, and everyone, all the organizers for bringing on board an excellent, brilliant faculty for this KUHS seminar on virology. Thank you all for the brilliant interactions. Thank you very much. Good day.
Thank you, ma'am. Now we invite the Vice Chancellor, Dr. Mohanan Kundumal, the Principal, Dr. Kala Keshavan, Dr. M.V. Pillai, Dr. M.K.C. Nair, Dr. Rajamohanan, Dr. John Panikkar, and Dr. Vasudevan onto the dais for the awarding function. We request Professor Mohanan Kundumal, the Vice Chancellor, to present a memento of appreciation to the speakers. We invite Mrs. Nora Samaranaike to accept our token of gratitude on behalf of Professor Robert Gallo. We invite Professor Anders Swanley to accept our token of gratitude. And we invite Professor Gagandeep Kang also to accept our token of gratitude. We now invite Dr. Raj Mohanan to present our token of...
Ms. Nora Rebecca is receiving on behalf of Dr. Robert Gallo, Professor Gallo. Thank you.
We invite Dr. Raj Mohanan to present our token of appreciation to the chairpersons, Dr. E. Srikumar and Dr. Indu P.S.
Dr. Dr. Say the announcement don't announce like this. Now, yeah, please, for chairpersons.
We invite Dr. Raj Mohanan to present our token of appreciation to the chairpersons, Dr. E. Srikumar and Dr. Indu P.S. Thank you all. Now we are moving on to the next session, the session on immunology.
Of pathology at Government Medical College, Kozhikode. Dr. Jayaprakash Madhavan, former superintendent of the RCC and head GI and lung cancer division. He is a senior consultant oncologist and coordinator at KIMS Health Center, Trivandrum, and is a founder member of the Alumni Association. The stage is yours, sirs.
Good morning to you all. This is a very important session on immunology. And to me, personally, it's also a very poignant occasion because it commemorates my very dear friend, Ramdas Pisharody. And it brings a lot of memories because he was my classmate in the 1972 batch right in this campus and brings a lot of memories. Of course, he will be introduced. He was a professor of nephrology here in Trivandrum Medical College as well as in other medical college, particularly Calicut, and retired as principal of this institution. He was always, when people speak of Ramdas, they speak in superlatives. Everything which was true. He was one of the most brilliant students to pass out from this campus, an exemplary physician, not only in nephrology, but also as a generalist and general physician. And above all, a great human being, as many of his patients as well as friends would attest. Our memories, particularly relating to immunology, goes back to our days of combined study, which we used to do. Immunology we used to study with the very first, even before printing, Dr. Ananthanarayanan and Panikar, the textbook, as and when it was being produced, we got the chapters because Dr. Ananthanarayan's son, Dr. Padmanabhan, was our classmate. So we formed a study circle to study immunology. And things were pretty simple. Actually, it's only serology mostly, precipitation, agglutination, and so on. Lymphocytes, just two types of lymphocytes, B cells and T cells. And T cells you detected by sheep cell rosetting. And nobody knew anything about the molecules, the receptors, the various molecules, the subsets of lymphocytes. Nobody even imagined that this cell that looked very simple looking cell in a peripheral smear could be so complex and with so many different families. So this is what we are going to talk about today. And Ramdas, if he had been here, he would have been very interested because one of his favorite pet projects in his life was the Mrida Sanjeevani project, organ transplant sharing project, of which he was the first convener of the project. And literally the first stages, he was the one who really built it up. And you know that in transplantation, how important immunology is in transplantation. So whether in suppressing the immune system for autoimmune diseases or for cancer, we know that we have exquisite molecular knowledge, genomic and molecular knowledge now, so that we can really act at various levels in these pathways. And the things have become so sophisticated that we have this immune checkpoint inhibitors and other kinds of treatments have been developed. And even we can make lymphocytes to work for us. The patient's own lymphocytes can be re-engineered and made to use as bio-weapons, so to speak of. And today one of the speakers will be speaking about the CAR-T technologies. And incidentally, we have two speakers, both of them alumni of this college, and they will be speaking on cancer immunology primarily, how Dr. Hari Parameswaran will be speaking on immunology of cancer, followed by cancer immunotherapy, chimeric antigen receptor T cells by Dr. Shabarinath Radhakrishnan. Both of them have done MBBS as well as MD from this institution. So I think we'll go on to Dr. Hari Parameswaran. Professor Hari?
Thank you, sir, for that, for introducing me, and I thank all of you for inviting me here. It's a great honor to be standing here, and also to remember Dr. Pisharody, who I had a good fortune of interacting a little deeply when I was a medical student, but unfortunately not thereafter as I left here. But, and the other thing is that when you stand here, you are taken back all the way to your student days. ഇവിടെ ഞാൻ ആദ്യമായിട്ട് നിന്നത് 1985 ഡിസംബറിലാണ്. അവിടെ അന്ന് ഒരു മനോഹരമായ ആചാരം ഉണ്ടായിരുന്നു, ഫ്രഷേഴ്സ് ഡേ. ആൻഡ് ഐ ഹാപ്പൻ ടു ബി ദ ഹാപ്ലെസ് ക്ലാസ് റെപ്പ് who had to inaugurate the Freshers' Day for our batch. People who have gone through the Freshers' Day in 80s and 90s will remember how wonderful it was. Not a great experience, but it was fun. And now many people who are in that milieu are here. I'm very thankful that we all get a chance to reunite too in this nice academic setting. So my talk is about the immune system. And Shabari, who's speaking next, is also, actually, I recently left my academic position to run a biotech research department. So Shabari and I, we were colleagues in our institution, and Shabari is carrying on the work. And it is great to see people come through. And Shabari's work is much more fundamental, so he'll be going into the depth of CAR-T therapy. And my job is to give you all a framework. There is a lot of, as Sir just said, immunology has moved on a lot from where we studied it in the early days. So I'll just kind of give a big picture overview on how much we understand cancer and the immune system and how we are using these technologies. We are using it. Immunotherapy is quite common. In Kerala also people are using these checkpoint inhibitors and all these things. CAR-T still has not come forward so much. So cancer therapy has moved quite a bit from the old days. From about 3000 BC, for multiple millennia we only had surgery. Then came Marie Curie and radiation. And very quickly in the 50s, there came the era of chemotherapy. So those are all DNA damaging technologies. So idea is to damage DNA of the cancer cells, prevent them from growing. But then there will always be a cancer cell that survives, and it's very difficult to cure metastatic cancer with just DNA damaging treatments. So we call it genotoxic therapies. So people like me who are big believers in immunotherapy, we call all those treatments genotoxic chemo, but we still use it even now. Then came targeted therapy, because some cancers are dependent on mutations that make them survive. So if you target that particular mutation, the classic example is Philadelphia chromosome, BCR-ABL, which leads to a BCR-ABL mutation in CML. You can actually block the protein produced by that mutation with a simple tablet, and that led to many other cancers where we have specific mutation targeting tablets. Then comes the era of immunology, where we started with checkpoint inhibitors in the 2010s, and now what I'm going to tell you is that the new era is what we call cellular immunotherapy, where we use living cells to establish long-term immune memory that prevents cancer from coming back. So these are the fundamental principles that we talk about. Immune system recognizes and reacts against cancers. So when you have a cancer, it means that your immune system has somehow failed. I wouldn't call it that way. I would say that the cancer has hacked your immune system and found a way to get past the immune system. The immune system is doing a great job, but this particular cancer managed to survive your immune system. So invasion of host immunity and how we restore host immunity is really the topic of this talk. Now, we know that from history. So this gentleman is called William B. Coley. He was a pediatrician. In those days, there was no pediatricians, there were only doctors in the 1800s in New York. He noticed that people who got erysipelas or Streptococcus pyogenes infection, some of these kids, their tumors went away. So he actually created a heat inactivated extract of Streptococcus pyogenes with a couple of other bacteria thrown in, and created a toxin called Coley's toxin, and he was injecting it into people like that gentleman there. And some of these people responded. And this was actually picked up by a pharma company, Parker Davis, that from the old days, you remember. And that was in use till the 1960s when the FDA finally said this is not, regular treatment, stop it. But it did work in a small minority of people. And what did Streptococcus pyogenes do? It basically created a milieu where there was inflammation. So we know that inflammatory milieus can sometimes reject cancer or attack and kill off the cancer. But we still didn't know what in that inflammatory milieu was doing it. So there comes the major enforcer of the immune system against cancer, that's the T cell. So we talked about Dr. Gallo, and unfortunately, people, whenever you talk about Dr. Gallo, people point out that he should have gotten the Nobel Prize. This is another gentleman who should have gotten the Nobel Prize. Jacques Miller, he's the guy who discovered T cells in one way. T in T cell stands for thymus. Jacques Miller found out that T cells go to the thymus, get educated. So what does a T cell get educated on? So our T cells are produced in the bone marrow from the hematopoietic stem cell, and then they migrate and they circulate and they get into the thymus. What do the T cells do in the thymus? In the thymus, they get educated on differentiating self versus non-self. So if you have a protein that has been with you from your genome from the beginning, the T cell somehow finds out that you cannot attack cells carrying that protein. If that happened, you would get autoimmunity, or life would be impossible. So that is the fundamental role of the T cell. So these educated T cells circulate in the blood, and we have a mechanism by which T cells can be activated. So typically they're activated with a protein that recognizes as foreign, and that recognition happens using a receptor on the T cell called the TCR, T cell receptor. So up at this point, we have T cells that are circulating that do not attack self, that can recognize non-self and get activated through that TCR, and in that setting, they undergo proliferation, and proliferation is driven by chemicals called cytokines, and the hallmark chemical is IL-2, discovered by none other than Dr. Gallo. So Dr. Gallo's fundamental contribution to immunology is the discovery of IL-2. So, and we can actually now take IL-2, expose T cells in vitro, and make them proliferate. So that is what drives all our adaptive T cell therapies, which Shabari and me and people like us do. Once proliferated, they can eliminate the cancer, but in the natural state, when the cancer becomes successful, the T cell becomes weak, exhausted, and unable to survive. So then the cancer growth happens. If the antigen is completely eliminated, meaning like if you have an infection, for example, you get COVID, your T cells will proliferate, they will kill the COVID-carrying cells, COVID antigen disappears from your body, and the T cells will contract and then become memory T cells. So the memory T cells remain for life. So this cartoon basically gives you the enforcement of T cells against either virally infected cells or cancer cells, etc. When cancer happens, it happens through 3 phases. So when you have the first few cancer cells in your body, we all are getting cancer cells in our body because cells undergo mutation. Cell division causes mutation. There is an elimination. So the main job is to eliminate these mutation-carrying cancer cells, and our T cells are doing it all the time. That is why people who have immune deficiency, children who are born with congenital immune deficiency, get cancers more frequently because of that, because the T cell enforcement of mutant cells is not happening at that level. So elimination is what should be happening. But if 1 or 2 of these mutant cells survive, then you get an equilibrium where the cancer and the immune system are in equilibrium. That is not necessarily bad, but that can then lead to the next place called escape. So why does this equilibrium and escape happen? Because the mutations, once a mutation has been induced in a cancer cell, the progeny undergo further mutations. So it's not just one single mutation. Some of these mutations are called driver mutations because that gives the cancer cell an advantage and drives itself. Some of the mutations are called passenger mutations because they are random mutations. They're like having a wart on your skin versus a mutation that causes hemophilia, for example. So in that level, the driver mutation makes the cancer go forward. The passenger mutation is just there. But T cells can recognize both. So the T cell immune response, this is, in the interest of time, I'll go quickly. Say that the main immune weapon is T cells, which attack the mutations, and we call these mutations neoantigens. The mutation produces a protein, and that protein is an antigen that was not present in your body before the cancer, so we call them neoantigens. So our hacking this system backwards to restore immunity means we have to restore immunity against neoantigens. And we have also, on the other side, we have also to make these exhausted T cells fight. So the lower right corner, I have a picture which shows you a naive T cell meets an antigen and gets stimulated, and when it can become a highly polyfunctional T cell that can stay around and kill cancer. That's one fate, and that's what we want. But if there's a chronic cancer sitting in the body or a chronic infection, say tuberculosis, what happens to the T cell then? The T cell keeps on fighting and in the end gives up. It exhausts itself. That picture is where the T cell kind of goes down, is called an exhaustogram. So we have terms for that. There is a term called senescence or aging of the T cell. There is a term called exhausted T cell. We can differentiate these in various ways, but that's not germane to what we're discussing right now. Ultimately, the T cell dies. We call it activation-induced cell death. So cancers, when they survive, that's what happens to the T cell. The T cell's kind of getting blocked from working against the cancer. And we can actually see this in tumor pathology. So if there are pathologists among you, if you do a CD3 stain to look for T cells in a cancer, you can see that upper left picture there is a prolific invasion of T cells, infiltration of T cells. That's a hot tumor with a lot of immune cells in there. And right below that, you can see the T cells are demarcated by a boundary. And that is a immune-excluded tumor, where the tumor is in the blue. The T cells have made a wall there because the tumor has put down fibrin and are preventing T cells from even entering there. So the tumor is actually fighting back against the T cells. And there are variations in between. So our job is to get past that. So this is what I told you in summary so far. Antigen-presenting cells patrol the body, and these T cells pick up threats like cancer, COVID, etc. They then evidence, once they become activated by seeing these new antigens or viral antigens, for example, they kill off those cells. So their job is to hunt for these cells and kill them. There are checkpoints in the cancer that can slow down the T cell activity, and over time, the T cells can be made to exhaust and die. One of these checkpoints is called CTLA-4, for which we have an antibody against now, and that's a way of treating cancer. And the other more common one, which we use right now, is called the PD-1 or PD-L1 antigens, which again, we have monoclonal antibodies that will block it. So that's how this thing works. So here you can see that the tumor cell has put up these resistance against a T cell. These checkpoints or these proteins block the tumor from T cell from acting on this, and you can actually attack that point. You can create a monoclonal antibody that blocks that interaction, and that frees up the T cell to fight the tumor cell. So that's one way of fighting back. Another way of fighting back is to take the tumor cell, create a vaccine outside the body, and there are several challenges to making cancer vaccines, but one of the ways is to put them together with a antigen-presenting cells like a dendritic cell, we call it a fusion vaccine, and give it back. So now the T cell can recognize that tumor cell. Third way is to do what we call adaptive cellular therapy, where you take the T cell itself out of the body, re-energize it, put it back in. So those are fundamentally the 3 or 4 ways in which we do that. Now you might ask, what about things like Herceptin, rituximab? These are monoclonal antibodies that we use in cancer. Those are passive immunotherapies. They're basically antibodies that target an antigen on the surface of the cancer. They don't restore immune memory. They don't actually create a cure, except as part of a chemotherapy regimen, for example. Immune checkpoints were discovered by these 2 gentlemen, Jim Allison and Tasuku Honjo. This was one of the fundamental discoveries of 2000, of the first part of this millennium. And you can see that why they are fundamental is because they can actually restore permanent immunity against cancer by just getting the T cells to go past this checkpoint. So here you can see that this is a T cell. It's trying to recognize this, but recognize this antigen. There is an antigen being presented here, and this would lead to activation. But by putting up this interaction, it is blocking the T cell from going forward. So T cell fails to get activated. That's what happens if you have CTLA-4. If you have PD-1, PD-L1 interaction between the tumor cell and the T cell, that leads the T cell to be exhausted. It's still there, but it's just not able to fight the cancer. So these two proteins, the PD-1 protein on the tumor cell and the CTLA-4 protein on the T cell. We now have monoclonal antibodies against, so they will come in between that interaction, and that immune synapse will not happen if that monoclonal antibody blocks that, so then the T cell is ready to attack. So that's the treatment called checkpoint blockade. We use it extensively all over the world. In Kerala too, I know many people who are taking nivolumab or pembrolizumab and getting fantastic results against diseases like lung cancer, which for which the natural history of lung cancer has been altered so dramatically by this. This is just a joke, actually. So when these guys got the Nobel Prize, on WhatsApp groups, we had a lot of these things. So somebody managed to say that Ekadashi Vradam, the purpose of fasting and autophagy is what they discovered. But it's not true. This is, fasting has, maybe its own advantages, and maybe you should fast to lose weight, etc. But it doesn't give you any immunity against cancer. So on that round, I think one of these things is that I have seen in the last 5-6 years is a lot of fake news that comes in WhatsApp. Every morning you wake up to 20 messages which promises these cures. One thing we can do as modern medicine doctors is to fight back. I do try to fight back, but it doesn't have to be acrimonious or a really bad fight. But I think it's our duty to fight back. Now, finally, what I do in my research and for my career is doing adoptive T cell therapy. So we told you that T cells get exhausted and senescent and inactive against cancer, so cancer survives. So our technology takes these T cells out of the body, and in many ways, through different mechanisms, we can re-energize and redirect them to engage with the cancer and eliminate it. Ultimately, people who believe in this type of technology think that it can give you living memory against cancer cells because T cells are long-lived and they become memory cells once they have successfully eliminated the antigen, and that memory T cells will restore permanent immunity against cancer, and this particular cancer will not come back. So that's the attraction of having living cell therapy against cancer. So this is called adoptive T cell therapy. And there are 3 great technologies that we use. One is a technology that I'm currently using mostly called TIL cell therapy. So what we do is we collect T cells from inside the tumor. So TIL stands for tumor infiltrating lymphocytes. Take the tumor, get the T cells from inside the tumor, expand them, and put them back into the patient. That's the technology. The technology that Shabari is going to talk to you next is called CAR T cell therapy, where you take T cells from the blood of the patient. So those T cells are not inside the tumor, they're from the blood, and re-engineer them to recognize tumor. So you take T cells and make them recognize a tumor. In the TIL cell therapy, the job is a little easier because they've already recognized tumor, they're trying to be there, so they're coming from the tumor. So it's a little bit more tedious though. And this therapy was pioneered by this gentleman, Dr. Steve Rosenberg, another major pioneer who has not won the Nobel Prize yet. And I think one of the highlights of my career is that I get to talk to him almost on a weekly basis. So, curing a solid tumor that is metastatic is the holy grail of cancer therapy. It's almost like in alchemy when we talk about a base metal being converted to gold. That was the holy grail for chemists for thousands of years. It drove a lot of innovation because people thought it could be done. In cancer treatment, metastatic cancer that has spread to multiple organs, to cure it is essentially impossible. There is a few exceptions, basically hematological cancers, maybe testicular cancer with chemotherapy, but without the rule is that's not even able to be done. And Dr. Rosenberg's group and TIL treaters, we have managed to do that at least in melanoma and in some other instances like lung cancer too. And finally, to summarize, what I just told you is the basic mechanism of immune system fighting cancer and cancer fighting back, and how we can hack that process. And we have 2 basic technologies: restoring the T cell immunity in an active process using adoptive T cell transfer, or other immunotherapies such as cancer vaccines, oncolytic viruses, we didn't even talk about those, immune agonists such as CTLA-4 and these checkpoint inhibitors that are used right now. And there are things like bispecific antibodies. Those are antibodies which can, on the one hand, bind to a T cell, other hand bind to the cancer, so it makes the immune synapse possible. So these technologies are going to revolutionize the treatment, and we will go to a phase where a permanent cure for many cancers, which can only be established by re-establishing active immunity against the cancer. And also, you don't need to eliminate every last tumor cell. So as Dr. Jayaprakash Madhavan will know, he treats a lot of lung cancer patients. You get these immune activations. You can get an equilibrium where the patient is taking the medicine and is going for 5, 6, 7 years without any problem. Because there may be a few tumor cells there, but the T cells are keeping them in check. You just need to re-energize from time to time. So the potential to cure metastatic cancer can only come from establishing immunity. And now, I think I'll summarize here. Thanks.
Dr. Hari for the excellent introduction of the topic. He has covered almost the basics of the immunology. Immunology has become a fourth pillar of cancer treatment. And in basic science, we should include cell biology and immunology as a separate specialty and should be give excellent training to our undergraduates. We'll go to the next speaker, Dr. Shabarinath Radhakrishnan. He is going to talk about a very new therapy, which is very new to India. Tata Memorial has just started the CAR T-cell therapy. So we expect RCC also will follow the path and soon start here also. Thank you.
Good morning, everybody. Thank you for the invite. Actually, it's a real honor to be here. Because as Dr. Hari said, the only other time that I stood here was completely non-academic. So today I'm going to talk to you about CAR T-cell therapy. I'm going to introduce the topic, give you the rationale, why we need to do this, how we're going to make CAR T-cells, and give you small snippets about current CAR T-cell trials that made these treatments approved, and why it has blockbuster status in cancer immunotherapy. It's really changed the world of a lot of cancer patients. It's changed the imagination of scientists, doctors, and it's really lived up to the legendary status it has acquired. Before we start off with CAR T cells, I just want to recap or kind of refresh your memory on how T cells and also B cells recognize tumors and antigens. So if you look at the T cell, and if you have a virus infected cell, the T cell recognizes small peptides only in the context of HLA molecules. So they are not going to recognize any surface proteins as such, but it's only small peptides, and also only in the context of HLA molecules that these T cells will recognize. It is a limitation and also an advantage for T cells, and they're designed in this way. In case of B cells, if you look at it, they make antibodies, and these antibodies can bind to proteins that are on surface. I just showed a bacteria which can on the surface, and so they do not require HLA, so they are not HLA restricted. As Dr. Hari said, the immune system is really robust, but still cancer escapes, and there are different mechanisms of tumor escape. I'm not going to go into that. But one major mechanism is where these T cells cannot recognize the tumor cells. There are multiple reasons. One is that they do not have the HLA and HLA on the surface, or they do not recognize any unique peptide on the HLA that the T cell can act on. And in case of B cells, because these tumors do not have any unique antigens which are tumor specific, we do not have antibodies against them, because by nature that is eliminated when we were very young. So how do we circumvent this problem? A very brilliant scientist from the Weizmann Institute came up with this idea of why not make antibodies against an antigen which is present on the surface of tumor cells, and why not swap the T cell receptor with the antibody? So that was the origin and the birth of the CAR T cell, as it is called. Initially it was called T-body. and it has come through many generations of iterations of the same. And essentially, what is a CAR? If you take the variable heavy and the light chain from this antibody, and then combine it with the T cell receptor, that is the CD3 zeta part of the T cell receptor, through a hinge in a transmembrane domain, you get a CAR, which is called chimeric. As the name indicates, it's a chimera antigen receptor. And the most important part is this single chain variable fragment. It's a name given to the combination of the variable heavy and the light chain, which is linked by a small linker. And so this is what is a CAR. And when you introduce this CAR into a T cell, it becomes a CAR T cell. And this CAR T cell still has a TCR because we have not modified it. In addition to it, it has a CAR that's a receptor. And this can actually recognize a tumor or any antigen on the surface of this tumor cell without an HLA associated with it. So how do you make one? So this is what I do in my research, and it's an interesting process that we have established to make CAR T cells. In the next few slides, I'm going to talk to you how we made a CAR T against this particular antigen called CD229, because our lab was focused on multiple myeloma, and myeloma being an incurable disease at the time when we started this discovery campaign. And CD229 as a CAR is present mostly actually on the lymph. So this is RNA expression on these different tissues. I don't know if it is really visible in the backside, but this is RNA expression on these different tissues. So as you see, CD229 is only expressed on lymphocytes and some bone marrow cells, but it really spares the rest of the organ system. This is very important because if you make a CAR against CD229 and this antigen is on, say for example, the heart, then your patient is going to die with heart failure before he's going to die of cancer. So this is a very toxic treatment if it is not done properly. So attributes of good antigens are, one, it should be present in limited expression. That is, it should not be widely expressed all over the body. Second, it should be present on most of the cancer cells that we want this antigen we want the CAR T cell to act on. And it should be expressed on the surface, because if it is not expressed on the surface, the CAR T is not going to recognize this tumor. If you look at CD229 expression on myeloma cells as we want it to be, it is expressed on almost all cells of the myeloma cells of patients that we looked at, irrespective of whether it is newly diagnosed or relapsed refractory. So we set up to make CAR T cells, and we have developed a CAR T cell development platform that we incorporate high throughput systems, which is in this box, and also low throughput system where we identify a specific clones that we want to further narrow and have detailed experiments done on. So it starts with antibody discovery, because we need an antibody to make a CAR T. And then you go through multiple screening process where we want to find the best binders that we want to make CARs from. And we test for cytotoxicity to know how good these CARs are. And then after we have some clones that we think are good, then we can go into have low throughput systems where we specifically look at specificity and also toxicity. So I'm just going to go through this process so that there are two aims. One is to actually show that this actually can be done in a regular lab. It doesn't really require very sophisticated instruments. It can be done anywhere in the world if you really want to do it. The crux of the, so I just want to come back to this previous slide, sorry. So the most important part, as you would recognize, is this first antibody selection. So without the antibody, you won't be able to make a CAR. And there are different mechanisms which out there that you can make antibodies from. Most prevalent is injecting mice with the antigen of interest and making hybridomas, and then getting antibodies from these hybridomas. But another very interesting technology is called antibody phase display library. So this is as the name indicates, it's a library where we genetically modify bacteriophages to express antibodies, human antibodies, on their surface. So each phage as is represented here, has a variable heavy chain, so human antibody, a heavy and a light on the surface of the bacteriophage. And the importance is that you have a phenotype genotype synchrony when you have a phage display library. That means whatever is expressed on the surface is coded by this by the DNA that we can later isolate. So if we find the binder that can bind to an antigen, we can easily isolate the DNA sequence for this, and we can make antibodies, recombinant antibodies down the line. So the phage library has millions of phages on it. So it has a very, very large number of phages. So and there is random combination of this heavy and the light chain, which is not present in our body. So this is random combination. So it can bind to stuff that normally wouldn't bind from our antibodies. We do selection is called biopanning. What essentially it means is you take an antigen, for example, this is CD29 on the surface of this on a surface of a plate, incubate them with this phage display library, and from the phage display library, some of them are going to bind to it because they have affinity for it. You wash off the rest, elute them, and then amplify them again. And each time you do this, you're going to enrich phages that are going to bind to our antigen of interest, that is CD29. So from this, we get a phage output, and then using the phage output, we can clone these clones into vectors that you can make, you can secrete these SCFEs from in bacteria. So what essentially this is, we took 296 well plates, that is 192 clones, express them as antibodies, and then look for binding against the CD29 using an ELISA like an assay. As you see, most of these clones don't bind, and only few of them actually bind, and of them, some of them are unique. And these unique clones, we moved from this format into a CAR format. So the idea is you need to screen in different formats because there is no guarantee that the antibody is going to bind to a particular antigen in all different formats. So from a SCFE, that is just the variable heavy and the light, soluble protein, now we're going to check for binding using a CAR format. And this we use with flow cytometry. So what we do is you take mammalian cells, transfect them with this CAR vector, and express this CAR on the surface of these mammalian cells, and look for surface expression that is on the y-axis using flow cytometry, and on the x-axis is antigen binding. So as you can see, some of these clones, they are expressed on the surface, but they do not bind antigens. But then a lot of them bind antigen and also are expressed on the surface. So from this, we selected one of them to make CAR T cells. So how does that work? So as you see, there should be a way by which we introduce this genetic sequence that is coding for CAR into your T cell. So you want to have stable integration into your genome so that it can be made constitutively. So for that, we use lentiviral packaging. So as like HIV viruses, they get integrated to your genome. So in the same principle, you have CAR plasmid, you make lentiviruses from these CAR plasmids, make lentiviruses, and then transduce activated T cells. So you activate them with CD3, CD28 beads, activate them, and then you get CAR T cells. It's a 10 to 12 day process where you need to culture these cells. But that's how, there are other ways to do it, but that's how we make CAR T cells in the lab. Then the most important test to know for efficacy is cytotoxicity, whether your cells are actually able to kill cancer cells. So the way we test that is we co-culture the T cells, either with the CAR T cells or T cells that do not have the CAR on the surface, so we call the mock CAR T cells, with these primary myeloma cells, and then we co-culture them overnight in different effector target ratio down here, and look for viability of these myeloma cells by flow cytometry again. As you can see, there is dose-dependent efficacy, different effector target ratio for these CD29 CAR T cells compared to mock CAR T cells. And these T cells get activated and makes interferon gamma, TNF alpha, and IL-2. So I say that these are activated T cells that are working against these tumors. And to validate our findings, we use xenograft models. Xenograft models means that you use immunocompromised mice so that they can take in, or you can engraft a human tumor. And what we do is here for myeloma, we specifically use a plasma cell leukemia cell line U266. You engraft them, and then after you sure they are engrafted, we treat them with CAR T cells after 1 week and look for tumor growth by a luminescence assay over time. So on the right is the imaging studies that are done every week. As you can see, the myelomas, so the mice that were treated with these mock CAR T cells develop tumor and they eventually die. But the mice that were treated with CAR T cells clear the tumor and they survive till the end of experiment. We kept them going for about 6 months. So this shows that this is really efficacious treatment for myeloma, at least in the in vivo models. This particular construct is in clinical development at this point of time. Hopefully, we'll see clinical trial sometime soon. In the next 3 slides, I'm going to show clinical data, just snippets of it, as to what really transformed CAR T cells in cancer immunotherapy. So the first patient was treated with CAR T cell was a patient with B-cell acute lymphoblastic leukemia. And she's still alive. It's almost more than 10 years since the first patient was treated in UPenn. So this is mature data from this multi-center trial phase 2, where 75 patients, pediatric and young adult patients with acute B lymphoblastic leukemia, which is relapsed refractory, not responding to any current treatment, was treated. And so as you see, the median blast percent was 74. That means these patients were teeming with disease. And the response rate is just unimaginable at the time, at this time when this study came out. Usually patients live weeks once you have relapsed refractory, non-responding BALL. And these patients survived, overall survival was 81%, unheard of. And some of them are still alive, and they could detect CAR T cells even 2 to 3 years after treatment. Similar in multiple myeloma, again a large study, 97 patients, again with a relapsed refractory disease. Almost all of them responded. So these are patients who have no response, who actually got CAR T cells. They all responded. 97% response. And the plots here, all the people on this graph are the ones that got a stringent complete response. That means that they did not have any evidence of disease at the time. And then some of them had very good partial response. And so very, very few people did not respond. And the median duration of response has not reached yet. B-cell lymphoma, again, the third one that has been FDA approved. Again, phenomenal responses. Like most people who treat patients with B-cell lymphomas will appreciate that they don't really survive months once they are relapsed and refractory. These guys have survived for like 18 months with 52% response rate. But there is still work to do, right? Because we only have 54% complete response rate. So this is where Dr. Hari pioneered one study at MCW. So the idea was, okay, so you have now 54% response with CD19 CAR. So what if we add another CAR on top of CD19? So we added a CD20 CAR. And so it has 2 CARs on the surface, CD19 and CD20, targeting diffuse large B-cell lymphoma. And if you look at these PET CT scans before and after treatment, the response is just phenomenal. It's just mind-boggling that patients can actually respond when there's so much of disease. And the other really important thing that I want to highlight is that the point of care CAR T cell production that MCW pioneered under Dr. Hari, which really democratized CAR T cell treatment. It's not restricted to any few centers in the US. Anybody who has a reasonably sized department can actually do that. This is a machine, there's a Clinimax Prodigy that is from Miltenyi Biotech, where it's a closed system. Once you put your cells and your reagents in, you don't have to do anything. You'll have your CAR T cell ready in like 10 days of production. And this is really, we do treat our patients in our hospital. We have our patients come in and we take their cells, make CARs and give it back to them. And we see the response. And I think that's something that many people would want to see all over the world. I would like to end with where this field is going. I know it's in its infancy in India, but all over the world it has made quite a lot of progress. I think where we're going to go is with off-the-shelf CAR T cell, because it takes about 10 to 12 days or 2 to 3 weeks to produce, and the whole process takes about a month from the time you're going to get CAR T cells. But the off-the-shelf one, you probably can get it like any other monoclonal antibody. That's probably where it's going to go. And then, armor CAR T cells, where you can make, in addition to CAR, it makes antibodies or cytokines that can augment CAR activity. But I think the most important thing for all over the world is the point of care CAR T cell. I think that and the global collaboration that is required so that this becomes available to more and more people who actually need it. And these are my acknowledgements. Really, I'd like to acknowledge my family and my friends, my mentors, and my funding agencies. And last but not the least, my dear friend, and friend of a lot of people here, who we lost about 13 years ago. It probably was my first mentor, and probably the reason why I stand in front of you. Thank you very much, and open for questions.
Thank you, Dr. Shabrinath. Talk. Yeah, it is because of the paucity of time. We'll have one or two questions we can ask.
So all the monoclonal antibodies that we talked about are B cell made. So they are made from B cells. Is that your question, or? Yeah, my topic was specifically CAR T cell therapy. So that's why it was, so there is no CAR B cell therapy, if that's what you were asking. No, it's only for T cells, because the effector function is T cell function. The B cell only makes antibodies.
Yes, so the natural role of B cells is to, B cells can recognize antigen that's floating around. So if you have a bacterial toxin, that's a chemical, the B cells make antibodies which then bind to that. To kill a cell, for example, a cancer cell, you need T cells. So B cells really, except for a supportive role, they don't have a real role in eliminating cancer. But these B cells' ultimate fate is to become a plasma cell and make an antibody. Antibodies, it's like T cells recognize bits of protein from inside a cell and then kill that cell. So it can kill COVID-infected cells, it can kill TB-infected cells, cell-mediated and cell-to-cell killing. B cells don't do that.
Thanks to both speakers for keeping to time.
Can we extrapolate these techniques to antiviral therapy also?
You mean CAR T cell therapy? So there are clinical trials, CAR T cells against HIV at this point of time. So there is extrapolation to viral infections too.
How optimistic you are in the cancer immunology to get defeating the cancer in near future?
Yeah. So I think the data speaks for itself, right? So, like 10 years ago, to have a B-cell ALL patient live 10 years down the line without treatment was unheard of. They would die in weeks. And somebody being alive at 10 years is really phenomenal. It's a cure, right? But we won't be able to cure everybody with one. So we will have different modalities of treatment that are required to actually get to there. But I think there is hope.
I think Thank you. We have exhausted the time almost. So one more question, one more. Yes, Kashi sir.
Acting on the T cells, can the T cells be down-regulated or modified in a transplantation scenario?
Thank you for that question, sir. We can actually, so basically the one way of looking at it is you can introduce genes into T cells to either redirect them and making more potent or also reduce them. So where we do it in kidney transplant specifically is we can actually do, so there is a donor, especially when you have a living donor, kidney, you can actually do what we call a reduced intensity bone marrow transplant first, and after about day 7 of that, you can put the kidney into that patient. Then there is no need for immune suppression. So we have done quite a few like that. I have personally done about 5 of those.
I think we can end this session. It's been very, very informative. And you can appreciate at what level immunology has reached today, what minute kind of knowledge that we have today. And particularly what Dr. Hari said was very important. Even at this time, we have one of the most selling products is general immune boosters, What he said, all these WhatsApp messages and all you have about immune boosting. And at a time when we have so much knowledge, we also, side by side, we have this kind of very spurious pseudo medicine also along with us. So it's all of us have to really fight against it also, as he very rightly said. Thank you very much, both of you.
We humbly request the chairpersons to present the certificate of appreciation to Dr. Hari Parameswaran and Dr. Shabari. We request Dr. M.V. Pillai to present our token of appreciation to the chairpersons. To Professor K.P. Aravindran. To Professor Jayaprakash Madhavan. Thank you all. Now we are moving on to the next session.
The next session is the Professor P. Ravindran Memorial Session, remembering a doyen of respiratory medicine. The chairs of this event are Dr. Aravind R. and Dr. Sudhindra Ghosh. I invite the chairpersons to take the stage. Thank you.
So, a very good morning to all of you. First of all, let me thank Dr. Panikkar and the organizing committee at the chairmanship of MKC Nair for dedicating this session on behalf of our beloved teacher, Professor P. Ravindran. As you know, Professor Ravindran was a doyen of pulmonary medicine in our country. And we have to see that the contributions made by Professor Ravindran in the field of academics as well as research is something that our institute will cherish till its end, because the contributions were so great, not only for the benefit of the patient, but also for the students as well as the faculty. You know, he joined the department of TB medicine when it was a primitive department in Pulanagota. By the time he retired in 1997, it has become one of the most prestigious training center of pulmonary medicine in our country. So such was the contribution, because you know, he is the person who started from DTCD to MD and made the necessary framework for starting pulmonary DM, because our current HOD, Pathagani, is happy because he is going to admit DM in pulmonology students from next academic year, provided our VC give every support for that. Dr. Mohan, the VC, see that pulmonary medicine students are admitted for the DM next academic year from our own department in our institute. You know, the contributions, because he is the person who started the first respiratory asthma and applied immunology clinic in our institute. This was the first in the South India. And in that center, he used to care patients with asthma and allergy and used to impart personalized patient care first in the country, you know. And he's the person with the collaboration of the College of Pharmacy. College of Pharmacy, he started the first antigen manufacturing units, which supported thousands of patients suffering from asthma. Then he became the vice principal of this institute. He focused his attention on developing the institute itself. You know, under his leadership, with a tough competition from various medical colleges in our country, we could get into the England-trained clinical epidemiology unit in our institute. You know, he was the director of the first CU in our college. And this is meant for training faculty in research methodology, clinical economics, social science, and biostatistics. We know currently we have so many faculties trained in these areas, and this is Dr. MKC is one good example, Professor Narendran, Dr. Shenai, Dr. Pisharody, all are trained under his leadership. You know, these are our pioneers of research in our country, in our institute, and we owe a great deal to Professor Ravindran for helping us. You should also realize the next generation faculty, he did many things because there was a tough competition under the England. England means International Clinical Epidemiology Units. They want to establish a training center for clinical epidemiology in India. See, they were searching for the different CU at that time. You know, the CUs were established in the All India Institute of Medical Science, Delhi. Similarly, Vellore Medical College, then the Lucknow Medical College, and there was a tough competition for getting this clinical epidemiology training and research center. Because of the leadership and vision of Professor Ravindran, the England accepted Trivandrum Medical College as the first clinical epidemiology training and research center, and we got it. And under that center, we were able to train many of the faculties for MPhil in clinical epidemiology. Currently, this is taken up by the university, they are conducting it. So we owe a great deal for Professor Ravindran for his visionary and helping us to establish that. So when we talk about Professor Ravindran, we should see that the contributions made by Professor Ravindran has a distinct place in the history of development of Trivandrum Medical College. With these few words, I again thank the organizers for dedicating this session on his behalf because he really owes it. And he left us in last year, 3rd April, but leaving behind a great legacy which we have to cherish. Thank you. Now I hand over the mic to my co-chair, Dr. Aravindan, to introduce the speaker as the topic.
Good morning. We will have two talks in this session on COVID-19. Of late, actually, monkeypox has sort of garnered the limelight away from COVID-19. But we should know one thing. This year itself, around 1 million people have died because of COVID-19 across the world. And the indirect effect of COVID-19 is obviously the lingering effects on multiple systems, of which the most important system affected is going to be the lung. And today morning, Gagandeep Kang madam did clearly mention that the recovery trial platform, the multiple investigational modalities were tried out against COVID-19. So majority of the interventions which had a mortality benefit, surprisingly, were the immunomodulator drugs. Previously, only for tuberculosis, we knew that the immunomodulators did have some mortality benefit, especially for tuberculosis meningitis. So it was really surprising to see that for an infectious disease, the drugs with mortality benefit happen to be the steroids, happen to be the tocilizumab, happen to be the JAK inhibitors, etc. So these two aspects, that is the immunology of the COVID, as well as the gamut of clinical presentations pertaining to the lung, that is the lung syndromes, will be dealt with in this session. And for the first talk, I would like to invite Professor Fatauddin sir, the HOD of Pulmonary Medicine in Medical College. Okay, sir. So he'll be introduced by sir.
I am very happy to introduce the speaker for this session, my colleague, Dr. Fatauddin, who is currently the professor and HOD of pulmonary medicine in our institute. You know, when it comes to COVID-19, Fatauddin has got a distinctive place in our state. Because, you know, during the first phase, we were not knowing anything about the virus. We are not having any diagnostic test at that point in time. And we are unsure about the therapeutic measures. At that time, Fatauddin bravely took up the leadership as a leader of the Korean COVID warrior team and managed many national as well as international patients in his institute at Kalambasheri. And the world recognized, even the BBC reported the successful management of Dr. Fatauddin in that institute. So he is such a person who has got a deep clinical knowledge with reference to diagnosis as well as management of COVID-related problems. And today, he is the current HOD, and he will be telling us his experience with reference to COVID-19 and what is the future that we have to expect with reference to this pandemic. Dr. Fatauddin, please.
A very good morning, distinguished delegates, my senior teachers, professors, my colleagues, and my chairs, Professor Ghosh and Professor Aravind. Thank you, sir, for your kind words. I am greatly indebted and in fact honored by the organizing team to allow me to present this important Professor Ravindran oration. And I take this opportunity to thank the VC, KUHS, Dr. Mohan sir, MKC Nair sir, former VC, and the convener, Dr. Vasudevan Potti, Dr. Vishwanathan Kavita, and the entire team who worked hard for the last so many months to make this event happen. So, my tribute to my professor, Dr. Ravindran sir, a great teacher, researcher and clinician and founder of INCLAN, MCH Trivandrum, and you heard the legacy that he left behind from our chairperson, Professor Ghosh. Now, you know that we have been hit by an unprecedented pandemic, a fatal one. A lot of water has been flown under the bridge. It has never come to a grinding halt. As Dr. Aravind was saying, the death continues to occur. But there is a lackluster attitude, and you know, we think that we have conquered this disease and we take it as very, very casual. Frankly speaking, a hell lot of research has gone in the last 2 years. Still, we fail to understand the exact long-term effect of this virus. We are yet to see what is going on. Nobody knows. A lot of papers have come. Since a lot of developed nations have been damaged by this disease, quick responses and vaccination has come. Otherwise, it wouldn't have come. So that is a good thing. There's a brighter side of it. But did the vaccination actually help us from eliminating this disease? No. If you look at this hall, including myself, we are not wearing a mask. We take it for granted that COVID has now become a very mild disease. So my talk at the end of this lecture would be on what happens if you get repeated round of reinfection. First, I will just concentrate on the lung syndromes, which is my specialty, and day in and out I am seeing a lot of patients even now. What I found was that this disease has now become orphan in the sense that the post-COVID issues, many have it. They are not probably presenting to the clinicians or doctors, and they are suffering it silently. Or they know that this is due to COVID, we are unable to help them. Now, quickly going through the very basics, if you look at the last 2 years, the first COVID X-ray when I saw, I was surprised. And it was coming only at the periphery. I did not know why it happens, only why it is gravitating towards both the subpleural peripheral patches as consolidation or ground glassing or whatever you call it. And this is the classic mnemonic presentations that we have seen in hundreds of patients in the first wave and the second wave. And now we don't know whether it will come back again with more predilection towards lung. Now again, with treatment, the lesions will come down, or many patients at presentation will have an X-ray like this. Now, what are the characteristics of patients who had COVID with lung infiltrates in terms of its long-term lung changes and the performance of the patient? So what are the people who are at risk of developing this persistent inflammatory lung changes? I wouldn't specifically use the word interstitial lung because it is not a ILD-like pattern. It was a misnomer. Initial literature said it can produce interstitial lung disease, but that is entirely different. This is a post-viral, post-infective inflammatory lung change. And who are the ones who are likely to get it? Predominantly male patients, obese, patients with diabetes, asthma. And the higher the inflammatory response, initially if the patient has got a high, what you call the COVID inflammometry, those patients are the one who are more likely to have residual lung problems. Higher levels of CRP and interleukin-6 during acute illness might lead to the formation of fibrosis and other lung issues. So when even now you must be seeing patients coming and telling you, I had COVID last year, or during the first wave, or during the second wave, or I had COVID 3 weeks back, or 4 weeks back. So when to consider the post-COVID change as significant? Most of the time, it will take nearly 4 to 6 weeks for the patient to settle in terms of clinical as well as its radiological presentations. If the symptoms as well as the radiological lesion persist even after 6 weeks since discharge, then we have to consider this as significant. And or another scenario, which we have seen during the second wave, the patient continues to progress radiologically and clinically despite all the interventions with continuous NIV support and remain oxygen dependent for a long period of time, beyond 4 weeks in the hospital in the absence of any pre-existing parenchymal lung disease, then this patient is also should come under the umbrella of post-COVID lung. Now, what are the, do all the patients who develop a COVID pneumonia will have all these problems? Not all. There are some predictors of post-COVID lung changes. One is advanced age, people above 60 years, severe COVID pneumonia, who are recovered, those who had gone to ventilators, NIVs, those presented with ARDS, and those who developed the classical cytokine storm and survived by treatment with tocilizumab, steroids, and ventilatory support and oxygen and anticoagulation. They are the ones who are likely to have more symptoms. And prolonged ICU or hospital stay also is a risk factor following COVID, and also ventilator-induced lung injury can also produce a persistent, long-lasting effect on the lung. And of course, alcohol is found to be a very high risk factor for persistent hypoxemic respiratory failure post-COVID. And this is also one of the causes of high mortality. Diabetes, diabetic ketoacidosis, most of initial phase, most of my diabetic ketoacidotic patients died. Alcoholics died, despite intervention. So how to evaluate the patient when you sit in your OP? Timeline since onset of infection is important. As I have told you, 6 weeks after discharge, it becomes more significant. Usually this patient should be seen 6 weeks after discharge. And they usually present with exertional breathlessness, which is non-quantifiable. If you put them into various tests, you run on all the tests, everything is negative. X-ray is normal, ECG is normal, echo is normal. But the patient complains of exertional breathlessness. I'll come to it a little later. And they have oxygen dependence and fatigue. And the only thing is, make sure that these patients are not suffering from any pre-existing lung disease like a bronchiectasis, tuberculosis, interstitial lung disease, or other congenital abnormalities. And assess the severity of the COVID illness during the acute phase, and then go back to the current presentations. So you can just review the radiology images. Probably you can have a fresh X-ray to see. Then you can also repeat the inflammatory markers like CRP, CBC, D-dimer, and an X-ray chest PA view, and resting SpO2 and heart rate. Then you can also subject the patient for a 6 minutes walk test, simple test which you can do bedside or in your OP, and a pulmonary function test if permissible. How often should one repeat the HRCT chest in the follow-up clinic? This slide I have put basically because post-COVID you have seen many patients coming with unnecessary CT chest, which is not indicated at all. That is why I have put this slide. Most patients might have taken HRCT chest for acute severe COVID illness, which is probably justified for the clinician to see how the patient responds to treatment. Most of those patients are in the ICU. And need to repeat CT in the post-acute COVID setting only if there is any acute worsening in the current X-ray or the chest radiology or significant worsening of respiratory failure, whether you want to see what is going on or is there any new other diseases have actually overlapped. If the patient do not have a baseline CT and the X-ray chest currently showing worsening, then you are justified in taking a CT chest. A repeat CT test is indicated only to assess the response to treatment in a small percentage of patients who continue to deteriorate. So what are the most common CT findings in post-acute COVID link? Radiologists are sitting in front of me, we see. And more than 50% of previously hospitalized survivors of SARS-CoV-2 infection will have some abnormalities in the CT, which is expected. And it will go with time. And if it remains even after 6 weeks since the onset of infection and more prominent CT changes in those with severe acute infection, then only you need to intervene. The most common CT abnormalities are ground glass opacities in the subpleural location, subpleural bands, interstitial reticulations, fibrotic changes, which those are all basically specialist jargons. Now I will just discuss a couple of real-life case scenarios which I have dealt with and the outcome. Now, I have a 53-year-old bus driver with no non-respiratory illness, non-smoker, unvaccinated for COVID-19, had SARS-CoV-2 infection in July 2021 with fever, breathlessness, cough, and fatigue. On 4th day of symptom, he was admitted in a private hospital. Initially was on oxygen and later was on NAV and was in the hospital for 5 weeks and discharged. But again, he was hospitalized after 2 days since the discharge and was in the hospital for 3 more weeks on oxygen and was prescribed some inhalers because of his relentless breathlessness. But he continued to have breathlessness and cough and came to our hospital with continued breathlessness and cough nearly 3 months after the onset of infection. This is the classical scenario where the patient is coming back to you again and again for breathlessness, most of them exertional breathlessness. So this is the X-ray. Initial X-rays were not available. In our hospital, I have taken this X-ray which shows only some marginal lateral infiltrates you can see on either side of the X-ray. But then the symptoms are disproportionate. And this is the X-ray taken 3 months after COVID. Most of the X-ray lesions appear, normal. You probably can just pass it as normal, but the patient continued to have symptoms, but the lesions have actually disappeared. This is the CT, which was taken 3 months after COVID, minimal ground glassing, few reticulations only. The classical pictures are not there. Very few ground glassing and one single gaze, you probably say that this CT is apparently normal. But what is his problem? The problem is he continued to have breathlessness. X-ray taken after that, almost normal. This is the X-ray. The symptoms persist, but is coming down. Treated with inhaled steroids and graded exercise, no features of fibrosis on the CT or X-ray. PFT shows a reversible small airway disease. So the learning point is the reason for his continued breathlessness on exertion was COVID can induce an obstructive lung disease, which can only be visible on the pulmonary function testing. So you prescribe a fellow with bronchodilators, inhaled steroids, and graded exercise and reassure him. That is the only thing that we can do. And remember, this guy was not a smoker. So this can induce, per se, small airway obstruction. Now, another lady, a 42-year-old housemaid who never had asthma or allergic rhinitis, had COVID 2 times at an interval of 40 months, repeated round of infections. Following which, she developed exertional breathlessness, rhinitis and cough, and thinks that she became asthmatic after COVID. She never was an asthmatic before. She never had asthma history, no family history of asthma as well. She had 2 emergency room visits in the last 3 months for breathlessness and wheeze. She feels better after inhaled steroids, but has breakthrough dyspnea in between. Her D-dimer level and PFT are normal. This is the X-ray chest. Normal D-dimer. Beyond 9 months, she continues to have wheeze and cough and breathlessness. So the point is, this can produce asthma. Post-COVID, first time somebody can develop asthma. This is because it causes non-specific inflammatory changes and bronchial hyperreactivity, which usually respond to inhaled steroids, but when you stop it, again the patient can have it. So if you have a post-COVID exertional breathlessness with no radiological abnormality and presence of desaturation, what is your diagnosis? Patient has breathlessness, X-ray is normal, but patient has desaturation. D-dimer should be checked, we all know. If it is high, CTPA should be considered to rule out pulmonary embolism. Hypercoagulable state may persist for a variable period of time up to 3 months after SARS-CoV-2 infection. Venous thromboembolism can occur during the recovery period after discharge from the hospital. Any patient with unexplained dyspnea with normal chest imaging post-acute COVID, you should rule out pulmonary embolism. So that is the learning point. Many a time, patients do not have any history of hospitalization. They just remain COVID positive, but after 4 weeks, 6 weeks, they either develop pulmonary embolism or they develop some regional thromboembolisms, either in the axillary artery or femoral artery or veins, or they may come to you with an acute coronary syndrome. Now, COPD, case scenario, post-COVID COPD worsening. This is the last slide that I'm going to show you. A 80-year-old gentleman, smoker, diabetic, and CAD patient. He was treated at multiple hospitals. CT taken last month had shown significant improvement in lung lesions, but his perceived COPD status worsened. With his breathlessness worsening, with his MMRC scale progressed to from grade 1 to 3 or functional class from 1 to 3, and he's on LTOT, long-term oxygen supplement. So this is a CT. CT shows some amount of emphysematous changes, not much radiological changes consistent with COVID, but he continued to have breathlessness and hospitalization. So post-COVID, COPD worsening is a major issue, and most of the time it is difficult to control. Now coming to how common is this post-COVID ILD. This is the most reported. So many antifibrotic agents have been put in the Indian market. So many physicians and doctors have used it even before 6 weeks, thinking that it is a COVID-induced pulmonary fibrosis. So the idea of this talk is to just convey a message that there is nothing called a post-COVID interstitial lung disease or fibrosis, and they do not respond to any antifibrotic agents, and there is no place for any antifibrotic agent. So what is the normal, natural history of COVID? Most cases improve. Most of the cases that I have shown you, initial CTs were abnormal, but with time they improved. Even after the radiological improvement, they continue to have extensional breathlessness. Most cases improve. Very few cases remain static, and very rarely progressive fibrosis occurs. So the term post-COVID should be precise with significant radiological findings, which has to be diagnosed and reported by a radiologist with traction bronchiectasis, bronchiectasis, and honeycombing. Now, this is the classical CT of a 42-year-old female in Trivandrum Medical College in October 2021. She came and she was in the ICU. She had gone into cytokine storm, treated well. This is a very, very frightening CT. This is after almost 6 months. The improvement has remarkable. And this is the X-ray in May 2022. So the message of this CT scan is that most of the time the lung lesions would disappear. So take-home message, I'll tell you, almost all cases will improve with time. Now, a few words about a repeated round of reinfections. Many of my delegates sitting here must have had COVID for more than one time. Now, this is the health advisory coming from Canada. What they say that each COVID infection put you at new health risk. People who get reinfected with SARS-CoV-2 have more health risk with each round of reinfection. So that is why I'm saying it is not benign. It is not good to have a second round or third round of infections. Each time your immunity, your what you call the acquired cell-mediated immunity will come down. Your T cell mediated immunity protection will come down. The immunity wall will be evaded and the patrolling of T cells will be diminished. Remember this is a US Health Secretary. He had COVID last month 2 times in a span of 28 days. 2 times. So there are many who gets COVID repeatedly. And there are multitude of long hauler syndromes, anxiety, chest pain, memory issues. Nobody is addressing all this problem because they don't have any objective evidence. But they are the silent sufferers. That's why I said this is an orphan disease. You have new onset diseases like diabetes mellitus, new onset, unmasking of asthma and allergic rhinitis I have shown you in the previous slides with case scenarios, worsening of pre-existing mild asthma, sleep apnea and fibromyalgias. Sleep disturbance is very common in up to 40% of cases. I had very bad sleep disturbances for running for 8 weeks. Brain fog, memory issues, depression and anxiety. So how do you treat all this? Exertional breathlessness and fatigue, brain fogging, not much treatment is available. But there are some interventions now coming in the literature like you can actually treat these patients with molecules like inspiritol, pyridostigmine, and oxaloacetate, which are the substrate energy supplying to the mitochondria. So now people say that your exertional breathlessness and fatigue is due to the poor energy supply to the mitochondria. So probably we'll have some impressive molecules in future to treat these symptoms. Why this topic is still relevant is because many patients are still getting repeated rounds of reinfection. And those who get repeated round of reinfection, what will happen to their memory issue? What will happen to their memory level? What will happen to their performance status and their fatigue needs to be seen. Thank you so much for your patient hearing.
Thank you, Fatah, sir. Please join us. For brilliantly taking us through the multiple manifestations of the post-COVID lung syndromes. Now the floor is open for discussions. We can have questions now.
Chairpersons, kindly note, we have time only for 2 questions.
Definitely. We'll take 2 questions. Sir, please.
The patient has no dyspnea, but the saturation is very low. Oxygen saturation is very low, but the patient has no dyspnea or no symptom.
Unless the patient has any other pre-existing lung disease, we cannot say. And the one situation where the patient do not have much dyspnea, where the saturation is low, but if you look at the ABG, that is normal is some dye poisoning, a textile dye poisoning and otherwise I have not seen anybody who is having no symptoms but desaturation. It occurs only in patients with congenital heart diseases, cardiac failures and things like that, to explain that. But they will usually have symptoms. Or a host of patients who are what you call hypoxemia adapted patients, like COPD patients. Their perception of dyspnea is different, and they have been exposed to this high level of carbon dioxide and low level of oxygen. They appear not much dyspneic at rest. But if they put them into exertion, they will definitely have symptoms and worsening of that desaturation. The only thing is desaturation occurs without much symptoms in a post-COVID setting. That is what I have shown on slide, wherein you have to certainly roll out a pulmonary embolism. Pulmonary embolism, when I say it is hemodynamically stable, subacute pulmonary embolism where the major pulmonary artery are normal. If you do a CTPA, till the last branches it will be normal. Then why this guy is dyspneic? It is basically because there are recent papers coming in saying that it is due to umpteen number of amyloid fibrin clots. It's called amyloid fibrin clots in the peripheral hair thin like pulmonary vasculature, which may not be, visible on the classical contrast enhanced CT pulmonary angiogram. That is why usually we treat them with 4 to 6 weeks of newer anticoagulants like apixaban or rivaroxaban. No, he was not. Happy hypoxia was a term which is originated in the Indian subcontinent, which is definitely not true. That is why during the second phase of COVID, when large number of patients are affected in Kerala, many died. Many of them are put on quarantine. They have been asked to stay inside by monitoring with a pulse oximeter. See, please remember, by the time a patient has a significant desaturation below 90, his lung has been affected extensively. So they are the not one who should be kept on quarantine with a self-monitoring of pulse oximetry. It was not true. So by the time they reach, it is too late. So the happy hypoxia is a misnomer which has actually caused many doctors to keep the patient either in their clinics or in the hospital and did not push them into the COVID care centers for further monitoring, evaluation and higher interventions. That is not true. And you know that patient who has got extensive bilateral lung lesions on NIV, talking over the phone, suddenly dies. Suddenly they are dying. They may be alert. The same thing happens in H1N1 pneumonia, where the patient is alert, talking till the last minute. That is the agony of this disease. So hypoxia, when it occurs, it is always significant. And early intervention is more important than late intervention. Late intervention may not be effective at all. So early intervention in the sense that when we have learned a lot from this virus. Initially, we did not know when to intubate. And the patient is talking like as you said. The bystanders are asking, my patient is talking to me over the phone, why do you want to intubate? So you just, take their side. You also want to play safe. You put them on NIV. They pull on with the NIV for 3 days, 4 days, 5 days. Suddenly, you decide that the patient is significantly hypoxemic and you put the patient on ventilator and he pops off. So late interventions, late intubations are another reason why we initially had a lot of deaths. Then we learned that earlier the better. If the patient is fine with all other parameters, there is no acute elevation, the patient is not in cytokine storm, then you may wait. Otherwise, you don't not only look at the hypoxemic status, you take the patient's entire status, whether this patient is diabetic, obese, any other comorbidities, post-angioplasty status, coronary artery disease. These patients, they die very fast, renal disease patients. So early intervention is the key and not late intervention. And there is nothing called happy hypoxia, which is an Indian subcontinent terminology. Not true.
Sir, what is the biological explanation of decreasing immunity with repeated infection with T cell? So we expect more and more immunity to develop, but why is it decreasing?
What they say is that each infection, each round of infection will put at least one of your organ more weak. More weak. Maybe at the heart level, or maybe at the kidney level, or maybe at the brain level, or maybe at the lung level. So the first 1 or 2 infections will actually shake your primary organs of involvement. And the second infection make that organ more susceptible to complications. It may not be the classical pneumonia. It may be some other issues.
Now, is it because of increased inflammation and increased response, or is it decreased response due to decreased immunity?
No. So ideally, when your T cell, as Dr. Hari was very elegantly pointed out, that the T cell mediated immunity is the cornerstone of protection against COVID, not humoral response and antibody. So there is no point in looking at antibody level after taking two COVID vaccine, or I took the third one, let me see, my antibody level is better than my friend. No, absolutely no use. So it is your cell-mediated immunity, which is the immunity wall that protects. It is the cell-mediated immunity that is getting weakened by repeated viral infections. The exact etiology is not known. A lot remains to be seen with COVID immunology. I think we should have a talk on COVID immunology by...
Sure. I think we will take up during that session. Thank you very much, sir, for the excellent discussion. Thank you.
The audience should remember that there are a lot of millions of people are infected by COVID-19. The percentage of people who may have that post-COVID syndrome, you see, that is very important. Is it 5%? Is it 10%? Is it 20%? The literature says between 10 and 20%. So you know the bulk of people who may be suffering from post-COVID sequelae in our country as well as globally. That is why this session. Thank you. Yeah, we can take up the rest of the questions after the...
Delegates, kindly note, we will be resuming this session with the second
It
speaker
will,
after...
across all strains. Thank you.
Thank you, Dr. Panikkar and the organizing committee. We as chairperson, thank you once again for giving us an opportunity, and also thank Dr. Fathahuddin for the excellent presentation of the topic. Thank you.
We request the chairpersons to hand over the certificate of appreciation to the speaker, Dr. Fathahuddin. We also request Dr. M.K.C. Nair to hand over the certificates to the chairpersons, Dr. Sudhindra Ghosh and Dr. Arvindran. Delegates, kindly note, we will be resuming this session with the second speaker, Dr. Nijal Haroon, after Professor P.P. Joseph Oration. Thank you. Now we have a memorial session of Professor Dr. P.P. Joseph. This session will be chaired by Professor Shaji Prabhakaran and Dr. Thomas Ibe. The Oration Award has been conferred to Dr. Rajashekaran Nair, inviting the Vice Chancellor, Dr. Mohan Kundumal, Dr. M.K.C. Nair, and Dr. Vasudevan onto the dais. We humbly request Dr. Mohan, Vice Chancellor, to kindly adorn the medallion to the speaker, Dr. Rajashekaran. We humbly request Dr. M.K.C. Nair, sir, to present the scroll to the speaker. We are moving on to the session, inviting the chairperson, Dr. Thomas Ibe, and the speaker to continue. To you, sir. Delegates, kindly note, the car registered number KL01BJ 4000 is creating a traffic jam. If the owner is here, please remove this car from the place it is parked at. Kindly note, the number is KL01BJ 4000.
Very good.
Good afternoon, everybody.
It is my great pleasure to welcome my guru, Rajan sir, who was my professor and director of neurology at Government Medical College, Trivandrum. We have already heard about him. He did his DM from AIMS, New Delhi, and he is a person who initiated the DM course at Government Medical College, Trivandrum. He is a prolific writer in Malayalam, and we have always cherished his classes at Government Medical College, Trivandrum. He is going to talk about creativity, which all of us have. All of us have creativity. It is not confined to only artists or anything. Everybody has creativity to a lesser or a larger extent, and it is interesting to note that our creativity is increased by taking holidays. Some of the people who have brain damage develop more creativity, and intelligence is not related to, it's a good thing that intelligence is not related to creativity. An important point, but if you are intelligent, you can work on it, that is all. And I think it all depends on your brain network. The default network where you don't think of anything, just that is called the default network. And it is the interaction of default network with the executive network and the salience network in the brain that is really going to improve your creativity. And we will hear from Rajan Shayan sir about creativity. Over to you, sir. Do you want to stay there?
Well, I'm indeed happy that I am giving the Professor P.P. Joseph Oration. Had he been in Trivandrum Medical College when we were studying, he would have been my teacher for MBBS as well as for MD medicine. But our camaraderie started in 1982 when I returned after my sojourn abroad. From 1982 to 2011, till he passed away, we were close friends. He was my, next slide please. He was my, next slide, go to the next slide please. Can you move it? Oh. Yeah, okay. Yeah, fine. Now, even after our retirement, we worked in the same hospital, Cosmo. He was my senior colleague, exceedingly good clinician, a great chap, and then indeed I'm very, very happy that I could do it. This is one of the last pictures where we went together for a public function that we were given an award by the hospital where we were working, the Life Achievement Award, and I'm indeed happy that I could collect this picture. Next slide, please. I think without wasting time, I'll go to my topic which is given to me, the neurology of creativity. Next slide, please. Now, actually, you heard very high-flown medicine in the last few hours. From the high-flown stuff, let me bring you down to the very common place. The common place is the most uncommon thing. Brain. It's a lovely poem written by Emily Dickinson. The brain is wider than the sky. For put them side by side, one the other will contain with ease, and you besides. The brain is deeper than the sea. For hold them blue to blue, the one the other will absorb as sponges buckets do. The brain is just the weight of God, for them pound for pound, and they will differ if they do at all, as syllable to sound. Next slide, please. Now, I'll come back to this. It's surprising that the amount of information which most of the medical graduates have about medicine, about brain, is rather not very adequate. It's about 1,350 gram weight only, but it contains 100 billion neurons. 3 times or 4 times of that glial cells. Thing which most of us even do not know is that 80% of these neurons are not in the cerebrum, but in the cerebellum. If you take the axons and the dendrites together, the total length of that would be about 8.5 kilometers, 8.5 lakhs kilometers. The word synapse is something funny. Initially, when it was discovered, the man who did it did not have a correct word. He called it as syndom. Later on, it is moved on to the word synapse. The synapse is hardly 20 to 40 nanometer in size. You have no idea the number and all. When you say these abstract figures, I'll give you an example. 100 billion neurons. We have no idea how much large it would be. The world population as of now is only 7 billion. If you take 1 million seconds, that would be 11.5 days. If you take 1 billion seconds, that would be 32.5 years. That is the largeness of it. Now coming to the synapse per se. The synapse is 20 to 40 nanometer. Old man like me, my hair is comparatively thin, and even that is about 80,000 nanometer. If you take a 80 GSM paper, the thickness of that would be about 1 lakh nanometer. That is the size of it. It is so complex as structure. It is unbelievably complex. Next, now I go on to the word creativity. The word which is used in Malayalam is Sargatmakata, but unfortunately that word, that translation is not really adequate. The term is usually reserved for artists, writers, etc., but not at all so. It is defined as the production of something novel and useful. Believe me, this applies much more for science rather than for art, even though in art it becomes so much of, what should I say, illustrative, productive. Next slide, please. Now I'll come back to, I'll go to this man, the man who did so much of work. A thing which is not really known is that a fairly large amount of work of Einstein is really that of his first wife, Mrs. Mileva Maric. And as luck would have it, in those days, women did not have any place in science, and hence she was taken back to the sidelight, and her name is not really known. It is not the Einstein which is important here, but Einstein's brain. When Einstein died, a pathologist stole his brain, ran away. He was asked by the office, by the hospital, to return that brain, where he just left with his store. He lost by that his job, his medical degree, his everything, to Harvey. And finally, sick of everything, he cut off the brain in so much, 240 sections or so, and didn't find anything seriously abnormal. He sent to every major center in the US to find out whether there is anything significantly abnormal. There are people who said that glial cells are too many, some particular region is a little more bulky, etc. But that is nothing. Structurally, it need not be so. That is the point that I want to say. In creativity, there need not be a structural abnormality. Next slide, please. Now, creativity can be broadly divided, as my friend said. Every one of us is creative in various degrees. The lowest is the dull form, the low working memory, low IQ. There may be psychopathology and brain damage. They have a dull output. Still, they are creative in their own way. I will tell you after some time, even in those groups, where is the pointer there? Yeah, fine. You keep it. Now, even in those groups, there can be wonderfully great artists. And the second group, I think most of us form in the middle, the little C group. We have adequate IQ, cognitive flexibility is there, we have better working memory. This is a really important thing, working memory. The big C, only a very tiny few people categorize to this. They have hyperconnectivity to a great extent among the neurons, among all cells. They have high IQ, they have cognitive inhibition, about which I will come. We come to the term normalcy. We all consider normal as a great thing. At least in neurology and in cognitive science, normal is the average or the medium. It looks rather ridiculous, but it is true. Long back, I wrote an article about one of the great Indians, and I said that whatever he brought out was because of his temperament. My teacher, a man who took his DSc in embryology in those days from Rochester, he asked me, tell me, how do you define normal? We really do not teach people the hypernormal states. It is the hypernormalcy which makes the people genius, workaholic, creative, etc. Normal is the humdrum of activity practiced with the majority of the scientists, the bricklayers rather than the architects. This is from one of my friends. His name is very, very familiar to all of you. A great writer, one of the best neuroscientists of the world now, V.S. Ramachandran. With the passage, the mask became the man and the ingenuity is written out of them. Next slide, please. Next. Now, all young kids, our children also, they were geniuses. To a terrible way, most of us knocked them down also. At the time of birth, the synapses are only 2,500 per neuron. One becomes in a year or so 15,000 to 20,000. Then they go on asking questions which you can't answer most of the time. You say Chumairika. This Chumairika means goes on and on, there's about. Even otherwise, the unnecessary proliferation of the synapses come down by the age of 8 or 9, then they become between inverted commas, the normal, the average or the mediocre. These windows of opportunity, we knock down, the adults knock down to a great extent. Next slide, please. I come back to some medical history. Actually, this gentleman, the one in the middle, John Fulton, he should have got a Nobel Prize, but he lost. I'll have to go a little previously also. Wilder Penfield, the man who did a lot of temporal lobectomies, temporal lobe studies, temporal lobe stimulation, for the epilepsy study, finally decided After about 1,000 surgeries and 1,000 studies, he said, look, I do not know what exactly makes the mind of a person, what exactly makes the thought of a person, what exactly makes the soul of a person. This is not the place, this is not the place where we study. It is in the time, a little before that, there is a chap by name Abraham Flexner who was asked to go around all the medical colleges of America and find out what's wrong with them. As a result of it, 31, except 31, all of the medical colleges had to be closed because he wrote a report saying that all of others are useless. So, big universities, including Harvard, Yale and all, they went on looking for bright youngsters. And Yale got this guy, the middle guy, John Fulton. It was he who started a great work in Yale University when animal experiments did not have much of what should I say, research. He removed the dorsolateral prefrontal lobe, that is this part, or the frontal lobe, that is this part, of two chimpanzees, Becky and Lucy. It was so surprising. Those chimpanzees were so aggressive, so much, what should I say, active. They became subdued. All the people who saw his chimpanzees, read his papers, were amazed at it. He was the greatest figure during the time. In 1935, in London, the International Neurological Conference in London, he presented the paper. By the time he had some problem which I will come to. Fortunately for him, he had a very good colleague, very good assistant by name Carlyle Jacobson, who would do whatever he is asked. He was as good as John Fulton. And John Fulton and Carlyle Jacobson presented a paper on these two chimpanzees whom they ablated the dorsolateral prefrontal lobe. Everybody was so much happy to see that those aggressive chimps became so much docile. But then, most unexpectedly, a person sitting on the back got up to ask a simple question. You have created docility for these aggressive chimps. After all, we have nothing to give to the insane persons. Why can't we do the same sort of surgery for the humans and make them docile, make them comfortable as much as we can? This gentleman never ever thought that this investigation, this study could be replicated in humans. He did not have an answer. In between, he asked who the questioner was. To his horror, he was told, he is the greatest man from Portugal. He ought to have got a Nobel Prize even long back for his carotid angiograms. For the first time in the history of neurology, somebody did the angiogram intracranially and got the cerebral angiograms. He did not get it. His name was Igas Moniz. On the top of it, he was a politician par excellence also. And Igas Moniz did not stop there. After the lecture and all, within about few months' time, he decided to do the ablative studies on the insane people. According to him, the results were brilliant, beautiful, etc., etc. And I'd like to say one more word about this. After about a few months' time, Igas Moniz found that is one of the most brutal surgery one could think of. But by the time it spread to US, a chap by name Walter Freeman took up it. And the story goes 50,000 people were submitted for this surgery all over US. Everyone became so docile, they just sat there like a living, what should I say, corpse. Next page, please. Now, in the undergraduate and graduate days, and possibly even for the DM days, we are taught about the, what should I say, the nice fascicles going here, there and all. But it is not so. It is all over brain. It is interconnected so much. Now that the diffusion tensor tractography has come, it has come to understand it's a beautiful one. I like to stay here for a second more. John Fulton, I told you, unfortunately, he was a tragic hero. He had his own personal problems. He lost the Nobel Prize, which ought to have been given to him, but given to Igaz Moniz for this work. And he became sick, and he died too early. Yale University did not have a correct person for a long time, and then they searched and found a great person whose name I want to repeat at least twice, thrice, any number of times, Patricia Goldman Racki. When she took over the work, it was brilliant. Next slide, please. When she took over the work, the animal experiments were practically not banned. It was made really difficult. Nobody could do it in a hurry. And by the time, fortunately, the MRI studies and other neuroimaging studies started coming. What Fulton left, Patricia joined. Fulton thought for a second that for the monkeys whom he ablated the dorsolateral prefrontal region, they're a very funny thing. Keep something in front of them. They see, they understand. Hide it or take it away. The chimps forget everything. According to them, out of sight, out of mind. It was he who pointed this out, and he had no idea what he was leading to. It was Patricia's work which continued this, and she said that the frontal lobe is the place for the working memory. If you take the memory as a whole, you have at the one region the the sensations which are perceived by the eye, ear, etc. That is one which lasts for about hardly 250 milliseconds. Then you have a shorter term memory, of which a part of it is working memory. There are people who differentiate it so well, but most of the people say that working memory is to be considered. That too lasts for about, less than about a minute or so, maximum a minute or so. Surprisingly, the number of things which can be kept in your memory for that short period is also limited. Miller, at a later time, John Miller has put the number as 7 plus or minus 2, that is the number which you can keep at a time. That is why most of the telephone numbers are still 7 here. You can remember them. In fact, it was Patricia who continued the work of Fulton, and it was she who said that the connection to the frontal lobe is not restricted from the ancillary region around, but from far away places, all the way from occipital lobe, temporal lobe, parietal lobe, etc. It is she who said, who started defining thoughts. What are thoughts? I'll come to the definition later. They do not know how many thoughts could be had. There are people, the people in neuropsychology, neuropsychiatry, neurology, hardcore neurology, they all join together. 86,400 seconds for 24 hours, of which 7 hours you sleep it off, you have still about 61,200 seconds. According to the neuropsychology people, that you have one thought a second. Make it one thought for 2 seconds, 3 seconds. Still the number can be abnormally high, unbelievably high. What happens to them? 90% of the so-called thoughts, they go like the milkweed fluff, appu pandari. They go, lie down and get lost. Some are different, a few of them. They are like the nuptial flight of the white ants. They fly, 99% of them perish. But a few of them, they lose their wings. They go to the hiding places, they mate, and they make the life miserable. And the next one is, some of the other thoughts are like magnets. They go on catching everything. Whatever that is happening, they catch. And, in fact, from the neuropsychology point, certainly it is important. The magnet business is equated with OCD, obsessive compulsive neurosis. And all the other way around, multiples of thoughts coming simultaneously, one after the other, one before forming, one before perishing. They all come together, jam these things, and make it worse. In fact, according to neuropsychologists, it would be at the schizophrenic one. Next slide, please. Next slide. Definition of thinking, possibly many might not have been thought of it, is manipulation of information to form ideas, concepts, problem solving, reasoning, and making decisions. Then intuition is an ability to understand anything instinctively without thinking too much. Imagination is faculty of forming new ideas or images of external objects when you don't get the stimuli for this. The imagery is visual images collectively. Now comes the last one, aphantasia and hyperphantasia. I ask you to shut your eye for a fraction of a second. Think of the people whom you love. Whether you can make their mental picture or your house, the place from where you are coming. To the horror of you, there is about 10%, 15% or 20% can't make the future. This is called aphantasia. This aphantasia, nobody believed that such a thing would be possible, but it is. In contrast with that, you have hyperphantasia. You close your eye and start worrying, start thinking about so many things. All of them you can make the images. Next slide, please. I have shut the eye and found that I could imagine so many things simultaneously without any difficulty. I can remember my teachers, the one above would be Professor Pai in America, our dear Ayya, Anantachari. And this one who is half there is one of the most brilliant teachers Trivandrum College had, G. Kavaria. And the background story is Hotel Chola in Tamil Nadu. And below that, any number of people, even name, where they have met. Everything I can remember in a second. This is hyperphantasia. Is it good? I believe it is certainly good. It makes me happy. At least remember these things. Next slide, please. Now, if you ask anybody what is thinking, the first answer which is going to come is, you are talking to yourself. That leads to talking, whether the language is there. According to Einstein, words or language, as they are written or spoken, do not play any significant role in the mechanism of my thought. He's right. The next is another great psychologist, the limits of my language limits my world as well. Let the angel of creativity be freed. Next slide, please. This is what Dr. Thomas Ipe has touched on. There are three major realms, three major networks. The frontal attention network, comprising of the dorsolateral prefrontal cortex there, and from there the cingulate gyrus and the parietal lobe, right up to the occipital lobe. From there, the language area, Broca's and Wernicke's, what happened? Yes. Can you make it? Yeah, I'll continue. The second network is, next one please, yeah, is the default network and the salience network. Salience is a switching network. It is the one which switches between the default network and the attention network. You let the default network do the trick. You become creative. That content that is in the medial frontoparietal network, medial prefrontal cortex, posterior cingulate cortex, insular and angular gyrus. Now the thing is, when your first network is active, you don't have the default network going on. When you are tired, when you are sick, when you enter in a jungle of confused thoughts, you suddenly feel that all the ways out are blocked, darkened. You do not know how to proceed. Still, you get a feeling, you get an innate feeling. A lovely little damsel of an angel is not not anywhere out of you, but right inside you, who keeps you happy, who makes you feel that, look, there is a way out. I am going to tell you. It is the salience network between the attention network and the default network. Next slide, please. When you are sick of all these things, when you are tired, you find that you could answer the questions which are cropped up in your mind, or somebody has asked you. You have no way to get it. Ideal thing, go back home. Sleep it off. Ideal. Or go to your spouse, help her out in her kitchen, cut vegetables, cut meat, cut anything. Or go a little more further back. You make her, you cut the wood, set it out. Or better, make a walk, take a walk. And suddenly you will find you go out of the place. It's a lovely poem written by a great poet in Malayalam. Onna എഴുന്നേൽക്കൂ വരൂ മുറ്റത്തോടവും മന്നി വെണ്ണിലാവായിടുവി വെൺപുഴയ്ക്കകമോ. Go out. Suddenly you will find that you get newer ideas, unbelievable, unthinkable ideas. I agree. The part of it is genetics, part of it is intuition, part of it is imagination, imagery, and much more important, you must have tons and tons and tons of experience. You must have gone out to the world to find out people, find out experiences, places. You get experience. Mixed with that, you have. Now, I told you, sleep is an exceedingly good way of getting it. And one of the diseases, narcolepsy, where you have a lot of sleep problems, including quick REM sleep, they do have a lot of what should I say, capacity for creative thinking. There are people who purposely slept it off and then brought out. I think Salvador Dali, Elias Harvey, and Mary Shelley. Next slide, please. I think I'll move very fast. This is about, again, the REM sleep, the breath of an angel, like a cool breeze, the fragrance enters. You know that it is coming, and you don't feel, you do feel, but you certainly have no vision of her. Next slide, please. Now, the amount of work which you need to bring out such a creative work is so much. I'll give you two examples only. I don't know how many of you have seen the MRRs with the cat's eye inside. What you get is rough stones. You take so much of work to polish it to bring out the cat's eye. This is a dove picture drawn by Picasso. He asked a man to pay him so much of money. The poor fellow asked, "Sir, you draw only a small sketch in a tissue paper and you are charging me." He said politely, "Look, for drawing such a picture, I spent 40 years of my life." Next slide, please. I'll come back to the last part of it, creativity in brain diseases. The one which a man who never had any creative activity may get abruptly creative thinking in frontotemporal dementias, and more so in autism, in GPI. Next slide, please. This is about syphilis, bringing out the creative part of the artist. Next slide, go to the next slide. Yeah, I think I am coming to the last part of it. You know, this is a schizophrenic Louis Vane who went on drawing the pictures of cat. It is interesting that you can find the degree of deterioration of his mental capacity by looking at the cat's picture, first row and the second row. Second is Seraphin Louis, Richard Dare, and Alfred Brooke. Next slide, please. Same picture of these three people. Next slide, please. I know that I have taken a little more time, but then can't help it. Thank you very much.
Thank you, sir, for the fluent narrative. And since this is an oration, there are no questions, I believe. There are no questions for oration. We will have a standing ovation. Thank you all.
We are humbly requesting Dr. Krishna Prasad to hand over certificate of appreciation to the chairperson, Dr. Thomas Ibe.
Sorry, sir, I have a little difficulty in walking, so.
We are now moving on to the next session, Dr. Joy Philip Oration. The Joy Philip Oration has been awarded to Dr. Matthew Thomas. We invite Dr. Matthew Thomas, the Vice Chancellor, Dr. Mohanan Kunnamal, and Dr. M.K.C. Nair to the stage. We also request the chairpersons, Dr. K.P. Ayyappan and Dr. Suma T.K. to the stage. The Joy Philip Oration Award has been conferred to Dr. Matthew Thomas. We humbly request Dr. Mohanan to adorn the medallion on Dr. Matthew Thomas. We request Dr. M.K.C. Nair to present the scroll to Dr. Matthew Thomas.
Actually, we have an apology. Yesterday, Matthew Thomas was in the list of distinguished alumni, but unfortunately there was some confusion in the list. And now I request our Vice Chancellor, Dr. Mohanan, to, along with, I request Ramakrishnan sir also, please come as the past president to present this Distinguished Alumnus Award. As you all know, Matthew Thomas sir was 1966 batch, 66 batch, and he was there. Yeah. Sir was the head of medicine, Department of General Medicine, as well as the superintendent, and right now he is working as the head of General Medicine in KIMS Hospital. We once again apologize to sir for our mistake yesterday. Thank you.
Namaste. First of all, I would like to thank the Trivandrum Alumni Association, its chairman, Dr. John Panikar, Dr. Vasudevan, Dr. Bindu, and all for permitting us to start the oration on our friend Joy Philip right away, this year itself. I remember it is in this hall in 1965 September. Myself and 181 aspirants of medical profession assembled in this hall in front of Dr. M. Thangavelu to take oath. That was the first function we witnessed in this hall, and this hall remains the same, and we are all here to Joy Philip Memorial Oration today. As you all know, we were 182 plus 2 or 3 added later, and of which 50 of our friends have lost their life. Joy Philip to the last. Joy Philip was a good student. During our journey through the medical school, you could find him as a brilliant student, one among the most brilliant of our batch, passing through, learning through, collecting all the syndromes every day. And he could get more than 12 gold medals during this journey of MBBS. And he married to Jilly Trisha, Jilly, our own classmate, and they have 2 children. Both are doctors, one is here in RCC and one is abroad at US. Joy Philip joined this medical college itself to take up the teaching profession, and during his journey, he passed the MD from here, and then he went on to UK for a fellowship in rheumatology. In 1983 or so, he returned, and started clinic in rheumatology also. He was a very good friend of mine, our batch, very good, loved person of the society at large. He was very empathetic, very sympathetic, very loving, and ever smiling person. We could all remember him, and even now his legacy, the smile and the love is there in front of us. And for the oration, we are getting our junior, Dr. Matthew Thomas, a very brilliant person, hematologist, and former HOD of this institution, now working in KUHS Hospital, and he will be formally introduced by my co-chairperson, Dr. Suma. Over to Dr. Suma.
Thank you, Dr. Hypen. To introduce Matthew Thomas, sir, to this audience may be superfluous. And you have just seen that sir has also received the Distinguished Alumnus Award from the alumni. Sir has did his MBBS in 1966 and MD in Internal Medicine in 1975 at this institution. And he has also received the Sri Padmanabha Memorial Gold Medal for Surgery and also Rotary Vocal Excellence Award in 2002. And he also has received the Best Doctor Award by the State Government of Kerala and Kerala State Award for Crisis Management. And he is now a very good worker in the member of the APA Kerala chapter. And there also he has received the Lifetime Achievement Award. And he was mainly focused while he was working in the medical college as assistant professor, associate professor and all that. His main interest was in hematology. And here the topic is systemic lupus erythematosus, my journey. So we know that when we started listening about the systemic lupus erythematosus, it used to be told as a triad of fever, joint pain and rashes. Then a lot of things have happened, a lot of manifestation, a lot of diagnostic points and investigations and management. And sir has worked from 2008. Professor Matthew Thomas has worked on systemic lupus erythematosus. I think without wasting time, I am inviting Matthew Thomas sir to give us a good picture about his journey with the systemic lupus erythematosus. Over to you, sir.
Respected chairpersons, senior alumni, and my dear friends. I first of all thank the organizing committee for choosing me as the orator for Dr. Joy Philip Memorial Oration. Everything about Dr. Joy Philip has been told. He was our dear friend, close friend, just 1 year difference. 1965 and 1966, we followed the same path, MD Medicine, and then we joined the Faculty of Medicine, Trivandrum Medical College. He retired in 2003, and I've retired in 2004 as the head of the Department of Medicine. A unique teacher, unique way of expressing things to the students and to the audience. Let his soul rest in peace. Now in 1980s, people with SLE, rheumatoid arthritis, we considered that as an orphan disease because there were nobody to take care of them. Only the specialties, major specialties like cardiology, neurology was coming up. So somebody in medicine had to take up their suffering and go with them. So I thought I would choose, and that is how my journey started with SLE. It was really an orphan disease, nobody to take care of these people. So I thought I will take, and the journey has started then, and it's continuing even after 40 years, though my primary interest is in hematology. And has the incidence of SLE increased? Maybe it has slightly increased, I think. A unique disease with a sex ratio of 9:1. And this is a drawing of a SLE patient in 18, lupus means wolf and erythematosus means reddening. The name was coined in 13th century and resembles wolf bites. So I'm not going into the details of SLE, but I'm mainly focused on the work we have done for SLE in 2009, bringing out an epoch, a curricula or treatment-changing drug called belimumab. That's my main center of the talk. So you know it's a chronic autoimmune disease with unknown etiology, and almost all the organs can be affected, and it's typically termed as a multi-system autoimmune disease. A thyroid disease, a uni-organ, where you have autoimmune thyroiditis, and you can have even a unicellular autoimmune disease like ITP, where a single cell is involved. And immunologically, it's characterized by presence of anti-nuclear antibody. Very heterogeneous disease. On the one hand, you have very mild disease with skin rashes and joint disease, and on the other, you have severe life-threatening disease where kidney and nervous system is involved. And luckily, this type of presentation is not very common. And with lack of pathognomonic features and characteristic diagnostic findings, sometimes diagnosis may become a challenge for many other physicians. Clinical features, I'll just rush through. It is termed under constitutional like fever, fatigue, arthritis and arthralgia found in many of the people. Mucocutaneous lesions, facial butterfly-shaped rash, skin involvement in the form of discoid, photosensitivity, recurrent oral ulcers, everything. This is the typical malar mash and joint involvement and the discoid lupus. Cardiac involvement seen in about 25%, involving every part of the heart, like pericardium, myocardium, endocardium in the form of valvular lesions, conducting system, especially in neonates who are born to SLE mother, it can produce heart block. Coronary arteries, we have got several patients with coronary artery disease. The small vessels are involved, not like the major blood vessels. Raynaud's phenomenon, vasculitis, thromboembolic disease. Kidney involvement in about 50%, and this is a single cause of mortality and morbidity in SLE. Gastrointestinal, 40% with mainly produced by drugs. Esophagitis, hepatitis, enteritis, and pancreatitis. Pulmonary involvement is not common. Neuropsychiatric involvement, many patients have been referred from psychiatrists after treating them for a long time and seeing no results and finding a high ESR, they refer to us. Hematological, that's very common. That's one of the reasons why I took up SLE, because all the three cell lines are involved. You get anemia. Leukopenia is one of the earliest manifestations in SLE, and also the platelets in the form of thrombocytopenia. And ophthalmological lesions are also there. Association, so many conditions like antiphospholipid syndrome, fibromyalgia, these are all associated with SLE. How do you evaluate a proper history is up in the list. Clinical findings which I have described and investigations, especially the antibodies, anti-DS antibody and the anti-Smith antibodies are very specific. And diagnosis is based on American College of Rheumatology guidelines, SLIC criteria, EULAR criteria, and classified into definite, probable, and possible. Differential diagnosis runs into many diseases like rheumatoid arthritis, systemic sclerosis, Sjogren's, vasculitis. And the main principles of management is under the following headings. Ensure long-term survival, which we have achieved, as you will see later. The lowest possible activity of the disease by measuring the ESR, anti-dsDNA, C3, C4. These are the markers of activity. Prevent organ damage, one of the important things. And decrease drug toxicity, increase quality of life, which we have also attained, and patient education. SLA treatment is mainly non-pharmacological sometimes, where we give skin protection, diet and vaccination. Pharmacological, it's different according to the severity of the disease. From mild to moderate, we use hydroxychloroquine, NSAIDs, corticosteroids, not a high dose, lower dose, methotrexate, mycophenolate mofetil, and the drug which I am going to talk, which we have worked a lot, is belimumab, and the newer drug, anifrolumab. Severe conditions, when that involves the kidney or the brain, we use cyclophosphamide and mycophenolate mofetil. They are found to be useful in that situation. And the prognosis has changed a very great extent in the these decades. If you say a SLA with a bad prognosis, if the renal nervous system are involved, male sex, when it is associated with antiphospholipid syndrome, 5-year survival has, in the 1950s, it was just 40%, and it has come to 90% after 1980s. So there's a great change in the life of SLE patients with a very increased 5-year survival. Mortality, though increased, it is about 2 to 5 times than the general population. And the causes of mortality are the organ involvement. Now, I come to the main part of my talk, where we had a very important drug introduced into the treatment of SLE, and our clinical trial was published in 2011 Lancet. Efficacy and safety of the drug belimumab in patients with active systemic lupus erythematosus, a randomized placebo-controlled phase 3 trial. What did the trial tell us? Researchers on SLA found that in SLA, the B cell activity is increased. So we were hearing all along B cell and T cell. So here also the B cell is very active, and it start producing autoantibodies like anti-nuclear antibodies, anti-dsDNA antibodies, and they have also found another cytokine-like substance which they termed as B lymphocyte stimulator. So probably this will come in the later physiology books, how B cells are controlled. This is an agent they found out, and they also found out a fully humanized B lymphocyte stimulator specific antibody, and that is belimumab, our drug we used in the clinical trial. It was a randomized placebo-controlled phase 3 trial. It was a global study throughout the world, 867 patients, of which we contributed 40 patients from our site in KIMS, and the maximum number was by the first author, Navarra, my friend, who is in Philippines. She contributed, or she recruited 60 patients. And in the trial, finally we found that there was a significant improvement in mild to moderate active SLE patients with statistical difference. So this was a pivot study, just changing the thinking about the treatment of the SLE for the first time after we had heard about SLE for a long time. So after this pivotal study, FDA approved this drug belimumab, and now it is called Benlysta. That is the name of the drug. And it is acclaimed as the first targeted biological treatment very specific to SLE. Before that, all the other drugs were non-specific, like corticosteroids, chloroquine. And this breakthrough study was presented in the annual meeting of the American College of Rheumatology in Philadelphia in 2009. Later, this drug was again approved for even lupus nephritis later on, along with the other drugs. Now, we analyzed our cases and we found that very important findings still. What were the important findings? It was found that by analyzing this 800 odd patients' records and study material, this drug reduces the autoantibodies. There were decrease in the, they normalizes the complement levels and reduces the select B cell population which were hyperactive. And these were the important studies which was published in Arthritis Rheumatologica in 2012. So this really told us that it could really reduce all the autoantibodies, and some of the patients' anti-dsDNA completely disappeared. And the Smith antibodies, antiphospholipid antibodies, all this disappeared. So this was the finding with the analysis of the patients. A significant reduction in anti-dsDNA and the Smith anti-cardiolipin antibody normalizes the complement levels. But the good thing is that it did not affect the memory B cells and T cells. Their functions were continuing. And also, there are definitely good antibodies in our body, and they were not affected, like the pneumococcal antibody and the anti-tetanus antibody. So this was a very important finding, that it affected only the cells which produces the autoantibodies in lupus and erythematosus, but not the normal antibodies that we have. Then we continued the study for about 8 years, and we asked the company to provide us drugs for the patient, and they were providing the drugs till it was approved and available in the market. So we were able to get this. This drug was given by an intravenous infusion every 28 days for 1 year. That was the initial study. Then we continued for another 8 years, but the number of patients decreased. It came to about 730 patients, and we continued for about 8 years trying to see what happens during this period. So this is the findings of this study after 8 years, which was published in Rheumatology, Oxford. Long-term safety and limited organ damage in patients with SLE treated with belimumab, a phase 3 study extension. So what happened is that 738 patients were in this study, and some of them dropped off, probably seeing the good effects. They do not want to come under the clinical trial again. And monthly assessment was done for 8 years. And belimumab displayed safety, stable safety profile with no safety signals, new safety signals. That means the drug was very safe and it was very effective. Minimal organ damage, progression over 8 years. But the cost of the drug is the one which is the limiting factor, which is probably a single injection is costing over 1 lakh rupees. So that is why many of our patients cannot get it. But probably in the future, we will be able to get it free or a little more less costly. And this is another study we did in pregnant ladies with SLE, what happened to them. So this was published in the Journal of Obstetrics and Gynecology. And the study was 73 patients we had. Mean age was 29, and 86 were diagnosed before the conception. And we found that though we had 33% of them were active, in their active disease, it did not cause much damage to the patient during the pregnancy. SLE activity had no impact on fetal demise, and fetal loss was only 14%. Now we come to the last slide. So this girl was seen 13 years back. She came to us with an acute abdomen in a very serious situation, and we found that she had a mesenteric ischemia, and which was blocking all the blood vessels and veins in the abdomen. We did an immediate surgery, and she became better. And then she was diagnosed as SLE, full-blown SLE, all of a sudden. And then we were able to make her better. She continued engineering studies, undergraduation, post-graduation. She got married, and now she's with a child. And one thing we advise the patient who plan to get married is the better half should know about the condition. So we tell them, unless you tell that, your married life will not be a good one. So many of them come back to us and ask us, is it a serious disease? Can she undergo pregnancy and childbirth? So we have got so many families who are doing well with children, going back to work. And so there's a great change in the treatment of SLE. And I'm happy to be with this treatment, and I'm still continuing my journey, and probably we'll have more people cured or more people better with this, with a good family life. Many of them are leading the normal life and normal jobs. So it is not a condition to be feared. It is a condition to be properly diagnosed and properly managed. Thank you very much.
Thank you, Professor Matthew Thomas, sir, for the excellent presentation about your trials on the baby bump and the advantages and also the effect of it on the pregnancy and the usage of it. I don't know whether the question is allowed in the oration. No, thank you. Not thank you. Thank you, sir.
The organizing committee would like to place its deep appreciation to Professor Matthew Thomas, sir, because he postponed his journey to Australia by 2 days to accommodate us. We are very grateful, sir.
Just one sentence is that I loved receiving this from the previous Vice Chancellor and the present Vice Chancellor rather than yesterday. Thank you so much for giving it to me.
We request Dr. Ramakrishnan Nair to hand over our certificate of appreciation to the chairpersons, Dr. K.P. Ayyappan and Dr. T.K. Suma. Thank you, sir. We now disperse for the lunch. Delegates, kindly note, we will resume the next session exactly after half an hour. Kindly assemble back soon. Delegates, kindly note,